Tcell, who's the additional professor of pediatric critical care at PGI Chandigarh. Welcome, sir. And Dr. Suma Balan, who's a professor and HOD consultant pediatric rheumatologist at Amrita Institute of Medical Sciences, Kochi, and she's also the chairperson of the Pediatric Rheumatology Society of India. Welcome, ma'am. Over to both of you for the first session.
Hello. Hello, everybody. It's a pleasure to be here, and I must congratulate both Chandrika and Dr. Akshay Shetty on a very innovative meeting. It's been very, very good to focus on this topic for the last 3 days. Today comes to the final end of our program, and today we're going to be talking more about therapeutics compared to what we've been seeing the last 2 days. With that, it gives me great pleasure to introduce our first speaker, Dr. Scott Canna. Dr. Scott Canna is an associate professor of pediatrics in the Perelman School of Medicine, University of Pennsylvania, as well as an attending physician in the Pediatric Rheumatology and Immune Dysregulation, the Children's Hospital of Philadelphia. He has been committed to translational research in autoinflammatory diseases and cytokine storm syndrome since 2005. This began with training in human translational autoinflammation at the NIH, where he contributed to the first trials of interleukin-1 blockade in patients with mutations of the NLRP3 inflammasome. It continued through work characterizing the murine models of macrophage activation syndrome. It extended to the discovery that the NLRC4 inflammasome hyperactivity drove both elevated IL-18 and life-threatening MAS. His independent research program began in 2017, working to elucidate the context and the mechanisms by which excess IL-18 promotes hyperinflammatory responses. Along the way, his group's biomarker work has identified the specific human context in which IL-18 rises above suppression by IL-18 binding protein, and IL-18 is free to signal. Translating this work, his group demonstrated that IL-18 blockade may be a rational and feasible treatment in NLRC4 mass, and they are assisting with the development of several clinical trials of IL-18 blockade. I'm sure we'll hear a lot more about this and much more. Thank you, Dr. Scott. The stage is yours.
Excellent. All right. Thank you so much for that introduction. Let me know if you can't hear me or something's wrong. But I just realized I'm wearing the same shirt today as in this picture, so I will stop showing that picture. So I have been asked to deliver a lecture entitled Decoding the Choice of Acute Therapy in CRS. And so in light of the fact that I am presenting here on the last day of this really great symposium, I'm going to present more of a structural framework that I use in how to manage these patients and less of the primary data. And so I'll apologize if some of this is a bit of take my word for it. But I think a lot of the primary data supporting this structure and these conclusions has been presented multiple times already in this symposium. My disclosures are not particularly relevant. So to start, very basically, why do we treat what you've chosen to call cytokine release syndrome? And the answer is not because of inflammation. In and of themselves, I don't think we think of fever or lab markers of inflammation as themselves being intrinsically damaging. It's more that they herald the damage that comes along with them, and that's in the form of immunopathology. And so when you're following a particular patient, the cues that you use to determine why you're going to treat them is to prevent and minimize this damage, and less as a knee-jerk response to the existence of inflammation. Whereas how we treat, or at least initially, is a balancing act between both the severity of the patient in front of you as sort of the sum total of both their inflammation and the damage, but also what we think is driving that hyperinflammatory response. The etiology probably matters as much, or in some cases more, than the severity, because how you're going to intervene needs to be targeted at that etiology. And the reason for that is, and maybe this will be controversial, but in my opinion, cytokine release syndrome is not a diagnosis. And we don't treat it like a diagnosis. And I'll try to make the case for that using a parallel example. And that example is shock. We don't think of shock as a diagnosis. We think of shock as a description of a physiologic state in time. And so this is from a recent review by people who are experts in shock, defined as a state of cellular tissue hypoxia, initially reversible, but must be recognized and treated immediately to prevent progression to irreversible organ damage. So it is a description of a dangerous physiologic state that requires urgent action. But we understand shock to be multifactorial. Blood loss is not the same as sepsis. We understand it to be graded. Not everybody is in the same level of shock, and it is not a binary state. It is not as though you go from no shock to complete shock. It is something that evolves over time, but it is recognizable and it is actionable. And the ICU folks in the audience know that recognizing and addressing shock, despite the fact that it's not a diagnosis, are incredibly valuable and life-saving. And so if you intervene, at a recognizable time, you can alter the course of this. But as I said, shock is a description, not a diagnosis, and it itself is an umbrella term that includes different categories: hypovolemic, cardiogenic, distributive, or obstructive, and all of this, all of you have been taught in medical school, and there are, literally dozens of different inputs that are not mutually exclusive. You can have both distributive and hypovolemic shock at the same time in the same patient, and it's important to be able to tease those out within, this entity that we call shock. And then you can intervene in ways that, one, are sort of targeting the whole of the umbrella, things that directly correct the physiology regardless of etiology. And these are things like fluids and pressors and oxygen. Or you can identify and target the many different and disparate causes that you've identified are contributing to shock. So we don't say that the patient has shock. We say that they are in shock due to the sum total of the contributors to their physiologic state. And so I would argue that when we talk about CRS, and I'm using the rose icon here to invoke Shakespeare's, what's in a name. We've talked about the nomenclature being a mess here. In the US, CRS is largely reserved to this state after CAR T-cell therapy. Rheumatologists call it MAS and HLH, and I'm not gonna weigh in on what the favorite is here. Simply to say that we do act as if there is sort of an overarching principle of hyperinflammation, or HLH MAS, or CRS as we'll call it. So can we apply the same sort of shock rubric to HLH? So then we have to answer a few outstanding questions, and the first is there even an umbrella? So many people have used this umbrella iconography, but we don't really have a definition for it, and we certainly don't have a name for it. And so I think it's worth sort of addressing whether there's even any there. Second is, okay, if there is such a thing as a broad definition of hyperinflammation or CRS or HLH-MAS, how do you treat it? What is a way that you treat this broad immunophysiology that's going to help in all the underlying cases? And then finally, how do you make categories and then ultimately subcategories of contributors to this state and thereby target treatments to those patients? So I think we'll try to address each of these questions. So first, is there even an umbrella? Dr. Cron, who's speaking later today, and I wrote a review where we sort of laid out what a definition of cytokine storm might be, but faced credible criticism. This is extremely broad. But if we look at the criteria we use for the various things that we call HLH or MAS, and this is a slide that's been shown before, there's massive overlap. The features that we use to define HLH, MAS, the H score, there's an MS score, are largely the same features, and we're applying them across multiple disease settings. And we recognize that individually, each of these are extremely non-specific. And so really it is sort of the sum total, and we don't quite yet have a gestalt of which exactly elements need to be included to define the umbrella. But certainly ferritin is one of them. And in most studies, if you don't have at least an elevated ferritin, you cannot sort of enter this algorithm. Now, certainly there's been folks that are operating, sorry, I had some animation issues, as if there is an umbrella. And we know this because many of the folks who have spoken earlier in this symposium have contributed to the generation of consensus guidelines for the management of HLH writ broadly in adults, or this NATO consortium on HLH. And so, you know, and they've developed treatment algorithms, and I'm not going to go through this, but I think if you are interested, this was in Blood in 2019. This is available online, you know, and it's sort of a multifactorial, multi-pronged approach that this one at least is very focused on the use of steroids and etoposide. More recently, a group actually specifically came up with guidelines for the management of HLH in critically ill children and adults in the ICU. And so they have a couple statements about treatment, the first of which is that HLH, including MAS HLH, is, you know, hard to discern, and it includes sepsis and MODS and other cytokine storms. And these are representing varying degrees, blah, blah, blah. But that this should be suspected in all critically ill patients with unexplained or disproportionate inflammatory responses. And the suspicion for HLH should be further increased for cases of rapidly evolving MODS and inadequate responses to appropriate empiric treatment or escalating supportive care. So in recognition that there was, you know, still a bit of a dearth of guidance, especially at these very early steps, often pre-diagnostically, and Dr. De Benedetti commented on this effort yesterday, we put together sort of a working group, largely of folks from North America, that included many rheumatologists, but also intensivists, hem-oncologists, transplanters, infectious disease folks, and including some patients and advocates as well. And we put together these points to consider for the early diagnosis and management. We came up with working definitions because there is no definition for this umbrella. We use the term systemic hyperinflammation, which is simply a state of damaging immune activation that is excessive or disproportionate to what would be expected for a patient's clinical context. So obviously, this is a very gestalt definition. This is not, you know, including the specific lab parameters. It's really, do you think this patient has immunopathology that's out of proportion to what you might expect for their clinical context? And then, you know, HLH-MAS is sort of the patients who have this suspicion, but then have the broad but recognizable pattern of clinical and lab findings that we associate with all these various criteria. So again, you know, overbroad, but at least sort of setting a framework for how we think about these things. And so, you know, this is how we organize this in an overarching way. This is our first statement, which is that systemic hyperinflammation is a continuum. The individual features are nonspecific, but collectively and longitudinally, they are recognizable and warrant prompt diagnostic evaluation. And then treatment may be warranted even if they don't satisfy specific criteria. And so our sum, and I think if you take nothing else away from this, one of the things we want to avoid is simply to say that if you meet some set of HLH criteria, that doesn't necessarily mean you need the HLH-94 protocol. It means that you have an immunophysiologic state that requires both careful investigation, but targeted therapy. So we're at least acting as if there is an umbrella. Although I am be the first to admit that this requires sort of better science to underpin how we define it. And so if there is such a thing as a sort of hyperinflammatory state, how might you treat its immunophysiology? And so again, we went back to some of the existing consensus statements, and this is statement 9 from this critical care guidelines. Where, you know, they set up sort of, this is my interpretation of their treatment algorithm, is if you have severe or persistent or relapsing disease, and you have, you know, CNS findings, and they are treatment naive, you might start with, actually, I think this is backward. If they have sort of MAS HLH, you might just start with steroids and IVIG. And if they have MAS, you might further consider anakinra and cyclosporin. And if they have really severe disease, including CNS involvement, or they are treatment refractory, or that they have familial HLH, sort of coming from I guess, right field here, you go right into something resembling the HLH-94 protocol with dexamethasone and etoposide. So this is one sort of treatment approach that I think tries to get at the fact that there's nuance both in terms of severity and etiology. And so the statements that our working group generated were along the lines of this, and I've tried to sum this up. So one, you should consider immunomodulatory treatment while testing is ongoing. Just because you don't know what's causing someone's hyperinflammatory state doesn't mean you shouldn't intervene. Two, how you intervene in that state requires balancing the risks of damage with the risks of both immunosuppression in a patient who might be infected and how you might obscure your diagnosis. If you're not sure if a patient might have malignancy, things like steroids and etoposide are potentially going to make that diagnosis much harder to make. Your initial stabilizing therapy options include things like high-dose glucocorticoids, anakinra, and IVIG. Our group really couldn't come to consensus on things we had less experience with, like IL-6 inhibitors, like plasmapheresis. But certainly there are situations in which those are well indicated. But we're talking about sort of broadly in patients without a known diagnosis. And then, of course, supportive care, appropriate empiric antibiotics, antimicrobials, and treatment of any known underlying triggers of disorders is essential right at the outset. Okay, so a little bit of data, again, coming from Dr. Cron's group, and I'm sure he'll talk about this later, about the benefit of the IL-1 inhibitor anakinra in treating secondary HLH, somewhat regardless of etiology. And so I put together this little pie chart of the patients that they treated and what their underlying etiologies either were or ended up being. And so, I think they saw a reasonable effect across all different kinds of etiologies, whether it was infection or malignancy or systemic GIA. You may have seen Dr. Carcillo present a case that we saw in Pittsburgh of someone with EBV HLH who had a very clear response to anakinra. And in this series by Dr. Cron, their best outcomes were when you initiated early, which I think makes sense, and in particular in patients who have systemic GI. So is there an umbrella? Yes. Can you treat the immunophysiology? Probably, but we need better data. And things like steroids and anakinra are probably our best shots. And so finally, how can we investigate the different categories and subcategories so that we can target treatments to these patients? And so, if we divide up the different potential contributors to the cytokine storm, infection, malignancy, rheumatologic, inborn errors of immunity, including familial HLH, and iatrogenic things like CAR T cells and bispecific tumor engagers, so we could divide this up sort of clinically or diagnostically. But when you don't know what's going on, that's not particularly helpful. So can we be a bit more mechanistic? And the answer is, I think we can. And I think that, availability of these tests is a problem, but it is a surmountable problem. Because everywhere I've put this little test icon is a place that clinically there are tests available. Now, almost all of these are simply ELISA tests. And so it's more a matter of finding labs that are willing to take on bringing it on board than it being the technical difficulty of measuring these things. Measuring IL-18 is not hard. It's just something that not a lot of labs have decided they need to do yet. And so I think our voices can help bring some of these things on board, especially if we continue to generate data showing their utility. So many of you have seen this before, that HLH is ultimately a problem of overwhelming T and potentially NK cell activation. Interferon gamma seems to be incredibly important for driving that pathology, either directly or indirectly through myeloid cells, including hemophagocytes, and sort of endothelial vascular activation, where effectors like IL-1 and IL-6 can be driving pathology, as well as coagulopathy as measured out by things like D-dimers and soluble C5b3 dyes. So all of these things we can use to assess what the dominant problems are in a patient. We can measure interferon gamma directly to say how much lymphocyte activation and gamma production there is. We can measure IL-2 receptor as a reasonable measure of T cell activation. We can measure D-dimers in coagulopathy. We can measure soluble C5b-9s for evidence of thrombotic microangiopathy, which sometimes accompanies the cytokine storm. And we can measure gamma readouts, things like neopterin and CXCL9. And then we have tests for actual etiologies, right? You should be testing for the infections, whether it's dengue, whether it's EBV, whether it's hemorrhagic viruses that you think are driving things. You can measure IL-18 in patients, especially who have a rheumatologic cause. We now know that most lupus MAS does not have crazy high IL-18, whereas all the systemic GIA and Stills does. And then, of course, you can interrogate both genetically and functionally perforin granule function. And so we also have medicines that sort of intervene at different places. And so I've tried to put them on sort of this spectrum between anti-inflammatory and immunosuppressive for how you might want to choose them. And so, things that might work broadly in this whole syndrome obviously include glucocorticoids, which have sort of a dose-dependent immunosuppressive effect. Ruxolitinib, which is a JAK inhibitor, which again may be sort of broadly helpful. We need more data. IVIG, I think, is a nice anti-inflammatory, helpful if you're worried about someone might be immunosuppressed, especially if they have a protein-losing enteropathy or a known immunodeficiency, but usually not enough. And then some of the more targeted treatments like imapalumab, which targets interferon gamma, or anakinra or IL-6 inhibitors. And then we have other drugs that, obviously are more targeted towards etiology. So, antimicrobials are incredibly important, even in a patient who clearly has HLH, if that's what's driving their immunopathology. Rituximab is a useful way of depleting B cells, both in lymphoma and potentially in some EBV HLH patients. There's IL-18 blockers coming on board, and we have a variety of sort of T cell targeted therapies, etoposide being certainly the one with the most data. So how can we use clues to choose tools to intervene in our patients? Well, this is, again, sort of just put together based on logic, but if you have a patient who's rapidly deteriorating, you need a fast-acting agent. So etoposide is great, but etoposide does not work, within 24 hours, at least in my experience. And that's where things like, antibiotics are critically important. Steroids, especially at high doses, very quickly can work. IL-1 inhibitors, potentially IVIG, and someday perhaps things like imapalumab, should they become sort of more widely available. We have sort of broader anti-inflammatories, again, steroids, IVIG, and cytokine blockers, and potentially someday other sort of more targeted anti-inflammatories. We potentially have tools that can help depending on your level of DIC or thrombotic microangiopathy. And in the sake of time, I'm not going to read through all these. These are not things that we use routinely. But when we detect that there's a problem, an outsized coagulopathy or strong evidence of thrombotic microangiopathy, these might be adjunctive therapies in particularly ill patients. When we have lots of evidence of T cell activation, we go after T cells. And so in some of our MAS patients, it's quite variable. Some of them have almost trivial elevations of soluble IL-2, and some have extremely high elevations of soluble IL-2. And that will influence your decision on choosing things like cyclosporin, or as the Karolinska group has shown, low-dose etoposide is probably a great choice in some of these patients that might have more T cell activation than your average MAS patient. I think that the jury is still out on the broad utility of things like plasmapheresis and cytokine filters. We're going to hear more about that in the next talk. And then IL-18 inhibitors, once those come on board, once you can measure high IL-18. And then, again, not to belabor the point, it's been discussed many times, but then specific etiologies, including, maybe someday we'll have specific T cells or antivirals against EBV. In the interim, we can deplete EBV infected cells with rituximab, except, and this is why there's 4 stars here, in EBV HLH, most patients will have infection of lymphocytes and B cells. And so if the predominant reservoir of EBV in your patient is T cells and NK cells, depleting B cells is unlikely to make a big difference in those patients. And we have seen this in our clinic, and more places are beginning to actually sort out cell subtypes to then be able to look at the EBV load within specific subtypes. So, I think these are things that we can do and are coming on board and that are clinically useful. And then, specific genetic etiologies like SAP or XIP or any of the familial HLH genes. So for one example, you might have a little baby who's had prolonged fever, high ferritin, cytopenias, and splenomegaly. And if this baby is stable, your workup could extend over the course of 1 to 2 weeks. You'll rule out infection malignancy. You might identify that this patient has perforin deficiency or strongly suspect it, and that patient should go directly on to HLH94 therapy as soon as you strongly suspect FHL. But this same presentation in a much less stable child who's bleeding, hypotensive, and maybe has hepatitis and encephalitis, now your workup needs to move much more quickly. And while it's working up, you're going to give this baby empiric antibiotics. You'll probably pulse with glucocorticoids. And if you have anakinra and IVIG available, you might give those as well to try to stabilize this child while you figure out that this isn't infection and malignancy. And eventually you start them on the HLH94 protocol once you think that that's the appropriate treatment. And so I'll point out here, and I put this in the chat a couple of days ago, that despite the fact that dexamethasone is the steroid of choice in HLH94, it is not nearly as potent as a pulse of methylprednisolone. So 10 milligrams per meter squared of dexamethasone is between 2 and 3 milligrams per kilogram of methylpred. And when we pulse patients, we use between 10 and usually 30 milligrams per kilo. So I'm going to skip the second example in the interest of time and just summarize and say, the ROSE, which your organization is called CRS, is an urgent immunophysiologic state, not a diagnosis, but it has value. It will cue you to look for the right underlying diagnoses. It will cue you to think about the right inflammatory stabilization. You then need to find the contributors that can include genetic risk, underlying diseases like cancer and autoimmunity. You can use biomarkers and functional tests within each of those to determine what's driving things. Is there more T cell activation or more autoinflammation? You can identify other triggers. You're pushed more by damage than simply by inflammation. And you're as interested in etiology as you are in severity. So with that, I'll thank all the people that have certainly contributed to my understanding of this. Apologize for going a bit over and happy to take any questions.
Thank you, Scott. That was a fascinating whirlwind account of, a bird's eye view at how you look at the entire spectrum of conditions that can present with hyperinflammation in our children. I'm surprised there aren't any questions, but I do have a couple for you. So one thing I've struggled with in the past few years is patients who come late to us, generally, all ages, but specifically in the adolescent age group who have prolonged fever, and they are already started on steroids for various indications by the time they come to us, and they are clearly in HLH by the time they reach us. But the problem is, workup hasn't been done, an adequate workup to rule out malignancies, and you don't really have any other clear indicator for a cause in these patients, for an etiology in these patients. And they've been on steroids for a while, your bone marrow, even your PET scan, nothing is going to be particularly revealing, especially if it's a lymphoma. Is there anything that we can do in the lab to pick up these patients? We've actually lost 2 patients whom we finally concluded must have been malignancy associated HLH. Is there anything we can pick up from a cytokine signal or something else in these patients to distinguish?
Not to my knowledge. I think that this is a situation that we face frequently. We recently in my institution lost a patient who had very aggressive and refractory EBV HLH, who ultimately, posthumously, we realized had a malignancy. Dr. Cron is putting uric acid in the chat. I'm not aware of data for that, but I think that, yes, if you see LDH up, I think that's very non-specific. If uric acid is quite up, then that's going to be helpful. But in my experience, that's often not up, even in malignancies. Leukemias, I think, are less often occult, although if they're pre-treated, it's very difficult. I'll admit I'm a rheumatologist, not a haemato-oncologist, and so I'm a bit out of my my element in saying this. But I think in general, you treat the severity of the patient if you don't know the etiology, and sometimes you'll end up in a situation where you still strongly suspect malignancy, and you've already treated with steroids and etoposide because that's what the patient needed to stay alive. But I think summarily, if you have HLH associated with malignancy, the outcomes are terrible. And I think that is likely to be even more intractable when you have a late presentation and a late diagnosis.
Thank you. There are a couple of questions in the chat, probably things we have been discussing in the last couple of days. So one is, in a country with multi-drug resistant organisms, is concomitant dexamethasone and antibiotics unsafe in a very sick child who's still early in evaluation?
I think that's it depends question. I think how much you worry about steroids unleashing their infection. I worry less about steroids in gram-negative bacterial infection than I do in infections like HSV. So I don't know that drug resistance necessarily changes that parameter. If your patient needs steroids to keep them out of the ICU and to assist their renal failure and coagulopathy, then that's what they need. So it depends balance question. I did see a couple questions about dexamethasone versus methylprednisone. I will say again, there is no way in the world that the increased CNS penetration of 2 milligrams per kilo equivalent of dexamethasone is better than 30 milligrams per kilo of methylprednisolone. And as Dr. Ramanan mentioned on day one, when you get to those higher doses, you're getting to sort of non-transcription factor binding efficacy. It works very quickly. You have to be careful for blood pressure and for press with pulse steroids and of course immunosuppression. But I think that dexamethasone is great for maintenance in HLH94, but when you're trying to get a patient sort of under control, I think a few pulses is probably more efficacious.
Thank you. I'll just take one more question from Aruna before we move on. It's an excellent question and something that I have in my mind too. Wonderful talk, Dr. Scott. Do you see a commercial panel of biomarkers on the horizon for more targeted early therapeutics? My wonder was that too. How quickly in your practice do you move on to checking your cytokine levels and the rest of the biomarkers that you showed us?
I am deeply privileged at my institution to have, within 24-hour access to a very high sensitivity cytokine panel wherein our interferon gamma levels are useful. The ones that go to some commercial panels like ARUP, the interferon gamma is not particularly sensitive, so we developed a different, more sensitive platform. We tend to send things like IL-18 and soluble IL-2 very quickly, even though we don't run them at our institution. I think that running these at your institution is, I don't see a company is unlikely to make money running these tests. And so that's why they don't exist. As I've said before, I measure IL-18 in my lab all the time. It's very easy. I have undergraduates who do it all the time. I'm happy to help any lab and tell you all the reagents. It's all in the papers we've studied. It's really more convincing your clinical lab that this is something to invest in. And I think that at some point we'll get there. I think that especially for me, soluble IL-2 and either gamma or CXCL9. And of course, if you don't have readily access to ferritin, I think that's probably the first place to start.
Thank you so much. Thank you very much.
Thanks for the invitation. This is a great conference.
Thank you. We'll move on to the next speaker. And there are more questions in the chat if you can fill in. Thank you. Arun, over to you.
Thank you, Dr. Suma, and thank you, Dr. Scott, for a wonderful talk. And carrying on forward, now we move on to the next very interesting talk by Dr. Claudio Ronco. I feel very humbled and privileged to introduce such a distinguished and learned speaker. Dr. Claudio is a senior lecturer and full professor at University of Padova, working at the International Renal Research Institute of Vicenza in Vicenza, Italy. So he is a nephrologist and at University of Padua, and is director of the laboratory of the RRI and the Beth Israel MC New York, and professor of medicine at the Albert Einstein College of Medicine. He has published amazing number of research and books, including more than 1,600 papers, 95 books, and 205 book chapters, and delivered lectures all over the world, around more than 900 lectures. His H index speaks for itself. It is 129. He has been editor-in-chief of 3 major journals like Blood Purification, Contribution to Nephrology, and Cardiorenal Medicine. And he has received multiple international awards, and he is the leader in the area of nephrology, including peritoneal dialysis and critical care nephrology. He has also invented the first CRRT machine for the neonates. That's amazing, called by the name of Carpedium. That's a cardiorenal pediatric dialysis emergency medicine. And this machine has saved hundreds of lives. And he's also founded the International ADQI Consensus Group and the International Renal Research Institute of Vicenza, where many international fellows have been trained. So it's really an honor and privilege to have you here, sir. And we would be very honored to listen to you. So you have the next approximately 20 minutes, and then we can have a few questions and answers at the end of your talk. So please, sir.
Well, thank you very much. I'm really honored to have been invited to speak about extracorporeal therapies for cytokine release syndrome. These are my disclosures, but beyond this, I must disclose that in spite I've several times worked in the area of pediatric nephrology. I'm not a pediatrician, so I'm an adult nephrology. The other thing is that in this meeting, where many experts on pathophysiology of cytokine release syndrome, I feel like a boy fixing cars versus a cardiac surgeon in the fact that I'm mostly presenting mechanical possible solutions to a very complex pathophysiological syndrome. Now, probably I don't need to go into many detail because cytokine release syndrome has been the topic of the conference, and therefore it is clear that the definition of a rapid release of cytokines into the blood from massive T-cell stimulation is very clear to everyone, as it is the fact that the effect of cytokines becoming endocrines and spilling over into the circulation may actually lead to a number of signs and symptoms that may configure a multiple organ dysfunction syndrome. It is well known what are the triggers and the fact that once activation of cytokines has taken place, this cytokine may trigger a further reaction which activates a sort of positive feedback with further cytokine release. We have already known this in the past, studying the macrophage activation syndrome and the hemophagocytic lymphohistiocytosis with the specific age score, clinical criteria, and knowing the high mortality. And in this occasion, the term cytokine storm was often utilized interchangeably with the cardiorenal, with the cytokine release syndrome. While they have a similar clinical phenotype, however, their characteristics are different, and when occurring as a result of a therapy, cytokine release syndrome may be delayed until days or weeks after treatment. Immediate onset cytokine release syndrome, severe cases are defined as cytokine storm that we as adult nephrologists are often seeing, especially in the setting of ICU. As I mentioned before, CRS occurs when a large number of macrophages or monocytes are activated and release inflammatory cytokines, which in turn activate more white blood cells in a loop of inflammation. At this point, it is important to know that this can occur in a number of infectious and non-infectious disease, including graft versus host disease, acute respiratory distress syndrome, sepsis, hemophagocytic lymphohistiocytosis, and viral infections, including SARS-CoV-2 that recently we learned more about. And of course, patients may have really fulminant syndromes in this situation where serum biomarkers of cytokine release syndrome are definitely elevated. There are several grades of severity, and I think we are specifically interested with our extracorporeal therapies in the area of life-threatening situations. Specifically, conditions with uncontrolled CRS can be defined as sepsis, septic shock, severe viral infection, and these are the therapeutic procedures that we propose in these patients. As you can see here, we're talking about an extracorporeal blood purification technique. What is, for example, the rationale in the sepsis cascade? Well, after invasion of bacteria from in the host and activation of endotoxin and recognition by the CD14 receptor, further problem occur when activation of NF-kappa B and activation in the nucleus may lead to overexpression of humoral and cellular effectors, leading to damage to the microcirculation and subsequently to different organ damage. Now, in this situation, extracorporeal therapies, contrary to drug, can be specific, for example, in the trying to remove circulating endotoxin, or can be aspecific in trying to achieve some immunomodulation when the immune system is dysregulated by removing cytokines. And finally, we can also support organ failure due to the different possibilities offered by extracorporeal therapies. In sepsis, as you know, the insult follows with triggers that can be pathogen-related or damage associated, and sensors of the host immune cells may actually go through different pattern recognition receptors that may enhance the importance of these two PAMPs and PAMPs molecules. Among the pathogen-associated molecular patterns, endotoxin is one of the most important, and it is clear that mortality is strictly correlated to the level of endotoxin in septic patients. For this reason, the idea that endotoxin is the trigger and correlates with mortality leads to the rationale of removing endotoxin well before the monocytes and macrophages may actually come to the activation of the cytokine cascade. And this can be done with a simple extracorporeal circulation through a sorbent device, which has been specifically designed to absorb endotoxin. And it has been demonstrated to work both in vitro and in vivo, removing a significant amount of endotoxin. In vivo, several studies have shown an improvement in SOFA score in severely ill patients. And in this study that we carried out several years ago, we also found 28-day survival difference, although the study was not designed to define a difference in mortality. So the problem, however, is that when endotoxin cannot be fully removed, the cascade may progress into a pro-inflammatory syndrome due to different mediators, but also after innate immunity as a response, there might be the response by the adaptive immunity, which creates a sort of antagonism. And therefore, while inflammation is a necessary evil, we have also patients that have problems related to excessive immunosuppression. And here are two cartoons designed by Hotchkiss several years ago that show that the innate immunity may lead to overwhelming inflammation, and patient may even die late with intractable inflammation, while the adaptive immunity may not be sufficient to counteract in this situation. However, there are patients in which the adaptive response is overwhelming, and you have made late deaths due to persistent immunosuppression and recurrent infections. So if we consider that the sequence of cytokine release can be theoretically pro-inflammatory and then anti-inflammatory, we could somehow figure out a sequence of potential targets for extracorporeal therapy to achieve immunomodulation. However, we have seen that the sequence not always is respected, and we have bumps with pro-inflammatory mediators and then anti-inflammatory mediators. And in some cases, there is a spillover into the circulation of both inflammatory and anti-inflammatory mediators. Now, our peak concentration hypothesis suggested that if I can remove enough concentration of cytokines that are circulating to lower the peaks of both pro and anti-inflammatory mediators, I may somehow restore a kind of immunohomeostasis in the patient, reducing the level of dysregulation. Unfortunately, these molecules are in a molecular weight range that very often cannot be removed by classic dialysis membranes. And as you can see, in spite of the improvements in permeability of extracorporeal membranes, we have seen that basically the removal of these substances is very limited. At this point, compared to classic diffusion and convection mechanism in hemodialysis and hemofiltration, we suggest the use of Hemoperfusion, enhancing the possibility offered by adsorption. And in fact, sequential extracorporeal therapy in sepsis is based on the idea that the patient may have increase in concentration of specific molecular targets that can be removed by different extracorporeal tools and devices. So, for example, infection, endotoxin, removal of endotoxin, immunodysregulation, cytokine release, adsorption of cytokines, organ damage and dysfunction, organ failure, organ support. Now, hemoperfusion done by adsorption is a technique which has been known for many years. However, in the past, there were many problems related to the incompatibility of the sorbent. Today, we have sorbents that are highly biocompatible, and they overcome the limitation of dialysis membranes. They are potentially selective on the process of removal, and you may place, as you can see here, the sorbent in contact with blood. Of course, the requirements are hemocompatibility, mechanical strength, no fooling or clotting activation, and well-designed cartridges. And as you can see here, you can put the sorbent in series with the dialyzer, both in a pre or in a post configuration. And here are some examples of how we use the different sorbents. And as you can see here, there are no problems of altered pressures in the circuit that are maintained stable over time. We have also a wide spectrum of sorbents for hemoperfusion. This is the case, for example, of the nitromacropolus resin and ion exchange resins and immunoadsorption resins provided by Jaffron in China that have made possible to tackle different potential pathological situations. For example, the HA330-380 cartridges has been indicated for sepsis, burns, trauma, cardiac surgery, ARDS, and pancreatitis, and also have been used in association with extracorporeal membrane oxygenation, where the cytokines are released due to the contact with the artificial surface. The resin has been shown to be very effective in removing cytokine and very highly biocompatible. We have studied this biocompatibility in specific experimental devices that we designed for this study. And as you can see here, there was practically no different in static and dynamic conditions in terms of viability of the monocytic cell line, no difference in apoptosis, and no difference in necrosis. So the material is strictly biocompatible and can be used. The other option is to test if the cartridges are fully utilized for blood perfusion. And so we use a CT scan study to perform specific flow dynamic analysis. And we have seen a complete utilization of the cross-sectional area of the device using different cartridges. Now, one of the first point is to make sure that the sorbent does exactly what it claims to be doing, especially IL-6 elimination. And in septic patients, there was a significant reduction of IL-6 levels versus no reduction in the control group, for example. This is another patient.
Actually, I'm not able to connect the headset.
This is another study in which removal of humoral mediators also is followed by an effect on survival of septic patients treated by hemoperfusion. And you can specifically see that there are no variation in the blood parameters, while there is a hemodynamic stability in the treated group, with reduction of interleukin-8 and interleukin-6 in 3 subsequent days of treatment. Once again, the important aspect is a reduction of length of ICU stay and improvement of SOFA scores compared to the level at admission. In this case, hemoperfusion was combined with high volume hemofiltration to provide also kidney support in septic patients. And once again, the reduction of IL-10, IL-6, and TNF-alpha were evident. Now, one of the applications that we used recently to test this hypothesis has been the SARS-CoV-2 infection that fundamentally was similar to MERS and SARS, where we had matured some experience as well. We have described in Lancet last year the different mechanisms that are affecting the kidney, for example, but different organs in SARS-CoV-2 infection. And beside all the other known mechanisms, you may see that the systemic release of cytokines represent one of the important aspects leading to endothelial dysfunction and kidney damage. And in fact, increased level of inflammatory mediators in plasma of patients with COVID-19 have clearly demonstrated this concept. And more than that, it has been shown that patients who develop this pro-inflammatory syndrome tend to present a specific level of mortality. So different treatments have been listed by the speaker before me, so I will not go into these details. While blood purification techniques have shown ability to remove cytokines and have shown that standard extracorporeal therapies like dialysis is not effective, plasma exchange may be. At this point, we published on potential mechanism of kidney damage and on the potential effect of cytokine removal preventing the cytokine release syndrome induced organ damage, which are well known, not just at the kidney level, but at the level of different organs, including the interaction between organs that may lead to specific damage. Now, in this situation, as you can see here, cytokine removal may represent one of the cornerstones in severely ill patients. And we published very early, February 6, 2020, before the World Health Organization declared the pandemic, that we had to prepare for extracorporeal organ support in intensive care because it was not possible to anticipate the extent of the epidemic. We knew that these patients were presenting with different syndromes, including gastrointestinal syndromes and cardiorenal syndromes. And therefore, we knew that our extracorporeal organ support system might have been of help in supporting different organ conditions. That's why we published this paper in Nature on kidney involvement and the rationale for extracorporeal therapies. And basically, you see that the viral infection leading to pneumonia and aggravated in some cases by the presence of ECMO and mechanical ventilation may lead to a systemic cytokine release with endothelial dysfunction and organ failure. Now, in this phase, as we meant before, there is an overwhelming inflammation. In this case, there might be an overwhelming immunosuppression, but in both cases, you may actually try to block this type of immunodysregulation using an extracorporeal hemoperfusion, very simple, placing the sorbent in line with the blood circulation, or in combination with the dialyzer, as described in this slide. And this has been used in several different occasions during SARS-CoV-2 infected patients. This is a typical case of a patient admitted with fever, hypotension, respiratory failure, high level of cytokines, hyperinflammation, treated with hemoperfusion for 3 days, leading to hemodynamic stabilization, normalization of cytokine levels, decrease of inflammatory parameters, and improved pulmonary exchanges. But not only that, we also found the specific biological effects, including reduction of cytokines, improvement in mean arterial pressure with reduction of requirement of noradrenaline, and specifically at the monocyte level, a sort of resolution of the immunoparalysis with restored capacity to respond to incubation with LPS and increased phagocytosis. And more than that, an improvement in the capacity of antigen presentation as demonstrated by the expression of HLA-DR on the surface of monocytes and the number of monocytes expressing HLA-DR. So there are several studies that have been somehow presenting this concept. This is one of the typical example where you can see that there is an improvement in patient oxygen saturation trend. There is also a expert review and recommendation on this concept that has led to the suggestion of utilizing extracorporeal therapies, including cytokine removal, as a cornerstone for the immunodysregulation and the cytokine release syndrome in these patients. We also did an acute disease quality initiative conference on guidelines to manage AKI and COVID-19 patients. And we published this report on Nature Reviews Nephrology, where hyperinflammation is considered one of the specific targets. And again, hemoperfusion is representing one of the possibilities, together with the possibility of removing endotoxin in patients that have a superimposed bacterial infection. So basically, the sepsis-like syndrome that may occur in COVID-19 suggested that you can use different extracorporeal organ support therapies that may represent an important part in the response to COVID-19. The question that arises was the potential and biological rationale for using extracorporeal blood purification in patients with COVID-19. Well, they have shown to remove cytokines, DAMPs and PAMPs, including endotoxin and circulating viral particles that are the triggers for the entire syndrome. More than that, it's important to consider which techniques, and hemoperfusion was considered probably the highest score for capacity to remove these substances. So the ADKI-25 on COVID-19 suggested different levels of approach depending on the stage of disease, on the pathogenesis of disease, on the treatment aim and the target for removal. And as you can see here, molecules such as cytokines represent a real target for extracorporeal therapies. So this seems to be a promising therapy. Patient selection is important. The phenotypes of patients are very different, and we need to clearly identify the right patient with the possibility to use specific biomarkers and achieve a level of biomonitoring that, despite the previous speaker said that in 24 hours can get a very good panel of cytokines, we will need a faster possibility to monitor these patients because we need to start early. Probably we need to change filter frequently because they may be saturated very easily. And for the moment, we need to follow the clinical status, monitoring adequate anticoagulation, and awaiting for further evidence on physiological and patient outcomes. One last comment is about the use of cytokine removing techniques in patients with extracorporeal membrane oxygenation. As you can see here, the sorbent circuit can be placed in parallel with the ECMO pump. And this has been actually done and studied in different situations, also in COVID-19 patients, where significant reduction of circulating cytokines were found compared to patients who simply developed ECMO therapy and high level of cytokines. And here you see that there is a high incidence of AKI, with AKI requiring renal replacement therapy in patients undergoing ECMO. And there is an estimated increase in mortality in these patients. So the possibility to prevent AKI associated with high level of cytokines represent an important aspect. We can integrate the circuit in a CRRT device, so there are no need for changes in the extracorporeal circuit. It's technically easy, is feasible, safe, and it might be effective. We need more studies to clarify this point. Certainly, in the patients that have been treated so far, and there is a larger study going on, you can see here a significant decrease in interleukin-6 that may be one of the triggers for AKI development. Combining HP with ECMO makes sense because we are at the level where cytokines are also produced in response to a bioincompatibility of the circuit, and cardiogenic shock or post-cardiac arrest can be a good indication, as well as ARDS or viral infection. Also, we need to know that ECMO is a trigger itself, and therefore elevated IL-6 may represent a target for this therapy. And this shown that this has been utilized worldwide. Increasing utilization in those patients where the CT scan shows very poor capacity of oxygenation. And there are studies, this is a case from Russia, for example, where reduction in interleukin-6 also displayed an improvement in mechanical ventilation effectiveness, or in this case, Dr. Natachai, that used the HA380 for hemoperfusion in patients intubated, displaying a significant improvement in PaO2 FiO2 ratio, which represents an important physiological target for this patient. AKI is common in patients who need ECMO, so it makes sense to prevent the occurrence of AKI, and blood purification techniques are available in this patient that may have an impending cytokine storm. I think there is a pathophysiological rationale for using hemoperfusion both in COVID and other pathological conditions with cytokine-induced hyperinflammation syndrome. Their cytokines represent possible target molecules, and studies should evaluate criteria for initiation. What I meant before for biomonitoring, we need to have biomarkers to trigger the application of these therapies and to monitor the effectiveness. And the suggestion is to identify patients who possibly benefit, start early, and monitor inflammatory parameters. One last comment about the possibility of using cytokine removal techniques in patients with CAR-T treatment or patients with cancer with specific therapies where the inflammatory level has been significantly reduced by the application of extracorporeal therapies. And here you see in particular reduction of CRP, IL-6, dopamine, and improvement in SpO2 FiO2 ratio in these patients after the procedures. In children, of course, you need to ensure the effect of blood purification while maintaining stability of hemodynamics. And for this reason, you need reduced cartridge with reduced priming volume, slower blood flow, and possibly using blood or blood products for priming. Nevertheless, we have today available pediatric cartridges for this opportunity, which are represented by cartridges that can remove the toxin and cytokines, or can even improve liver function by removing significant amount of bilirubin and bile acids. As you can see here, the size of these cartridges are significantly reduced. So we offer a new clinical option for children. There are contraindications in case of allergy to the sorbent material, which has never been documented so far. And the other are possibility of bleeding in the use of anticoagulation, possibility of hypotension or anemia due to severe systemic infection that may be further aggravated in some cases by blood leaks, although this is a very rare complication. Thrombocytopenia is also an important aspect to monitor. So in conclusion, I think that adsorption represents an interesting option for blood purification in patients with COVID-19, but also in any other type of cytokine release syndrome. Different sorbent materials are available, and modern chemistry can help because of optimal biocompatibility. Also the possibility to functionalize the beads and create a specific adsorption, as in the case of cytokines or endotoxin. We can test this through specific isotherm, and we have different options for different circuits for utilization of sorbent in practice. And sorbents may represent the new frontier in extracorporeal blood purification technique. With this, I thank you very much, and I hope I'm not being too long.
Thank you so much, Professor Claudio, for such a wonderful talk. You have taken us through a lot of evidence and the benefits of the use of the extracorporeal therapy, which is you have clearly shown that it does benefit in the outcome related to the duration of hospital or ICU stay, decrease in the SOFA score, improvement in the cytokine markers, and probably in mortality. And also, you also took us through some of the pediatric literature and how the innovations have helped. And we have seen that now we do get these filters by Baxter and Fresenius, which were not earlier available in India, but they are now. But not easily, but we do get those. And we are now started using the, maybe the frequency has started increasing in pediatric patients, both in septic patients and COVID patients had made us more knowledgeable or experienced in this. There are few questions on this. Due to shortage of time, I'll just take a couple of them. Important one is that, like we all know, the benefit is definitely there, which you have shown. Important is the timing, when to start this. Do we have any of these clinical or biochemical markers which will say that the patient will really benefit when you start these therapies?
Well, as I mentioned before, we have this dilemma on when to start and how to perform and when to stop. And we have three dimensions that can help us. One is the chemical dimension. This is what typically we use for dialysis when there is an organ dysfunction. For example, we measure urea kinetics to define how much is the need for dialysis, how much efficient is the system to remove urea, and so on. But this is of little help in this complex syndrome. Then we have a clinical domain dimension, which has been the ones that has made clear the rationale for application, because we all know now that after a few hours we apply these therapies, patients improve the level of hemodynamic response and the endothelial response, and require less noradrenaline and improve myocardial function and tend to improve diuresis. And also, finally, they have a better general clinical response with improvement of SOFA score. The third dimension, which is the crucial one, is the biological dimension, and it would be the measurement of cytokines. However, measuring cytokines here and there does not make too much sense, because the half-life of these cytokines is so short that you may find peaks and valleys, and you have hard time to interpret the data. So one of the important aspects, in my view, would be to make available the panel of cytokines, which should be made available at the bedside, so that we can have it as a point of care to guide our therapy. And two main messages are required. One, are we in the hyperinflammatory or are we in the immunoparalytic situation? The other, are we in conditions with high peaks of these substances so that our extracorporeal therapy makes sense? For today, our extracorporeal therapy is totally aspecific. So somehow it acts on the concentration of those cytokines that are at the highest level, trying to re-equilibrate a level of immunohomeostasis. In the future, when we have the biomonitoring available, we can also functionalize the sorbent in order to specifically absorb this cytokine or the other one. So I think it's a story that is developing. As you have seen, we have now different sorbents. We have polymyxin B, we have cytosorb, we have Jafron cartridges, and it is very important to go on with research, because I think it's a very, very promising approach.
Thank you. Thank you so much, Claudio. There are loads of questions in the Q&A and the chat box. So due to shortage of time, can I request you if you can reply to those questions in the chat box or in the Q&A box?
I can certainly do that. And I would like just to ask your permission to share for a moment this slide, because I think people might be interested. We are going to have our CRRT and AKI meeting in June in Vicenza, and we will discuss a lot about these topics that we have discussed today. So in case you're interested, please write to me or contact our organization, because I think we have also a pediatric session, and it might be helpful to expand the discussion we had today.
That's awesome. And if you can also put information about this on the chat box, it will be useful for everybody. So that will be great.
Okay. Okay.
Yeah.
Okay.
Thank you.
Sure.
Thank you. Thank you so much, Claudio, for your time. It was really an honor listening to you. Thank you so much.
Thank you.
So moving on next is another interesting talk. We are going on to the debate in which two great and young speakers will be there, Dr. Vasudha and Dr. Vignesh. So starting the debate will be with Dr. Vasudha. She is a trained, she's working at Rainbow Children's Hospital, a hematologist, and she has been trained at Great Ormond Street in UK. So Dr. Vasudha, please.
Thank you, sir. Good evening, everyone. A big thank you to the organizers for having me on board for such a niche conference. I hope I'm audible and my slides are visible. I'm from
Yes, you are. You are. Please.
Yeah. So I am from a pediatric haemato-oncology background. Sorry, just one moment. Yeah, that's better. So I'm from a pediatric haemato-oncology background, and I will be proving my point for the use of HLH protocols, HLH 2004 and 94 in the management of secondary HLH in PICU. So from all the talks, the superb talks that we have had so far, I think we have understood HLH, CRS, MAS, whatever you want to call it, really well. It is an acute and rapidly progressive syndrome, or an umbrella of syndrome, so as to say.
And slides are not moving, Dr. Vasudha.
Slides are not.
You'll have to make it full screen, not the presenter view.
No, I have made it full screen itself.
Just exit the presenter view and go on to.
Now?
No.
Right now you're in presenter view. Yeah.
No, I have exited the presenter view actually.
Just go to full screen. Or probably just close the presentation and open it again.
Sure. Just one moment.
Recording in progress.
Vasudha, you need any help?
No, sir. Just give me a minute. Just trying to open my presentation again. Is my screen visible now?
Not yet.
Not yet. It's still opening.
We could probably go to Dr. Vignesh's presentation and come back to you next, if that's okay.
Yeah, I think that's a good idea. So
Sure.
maybe Dr. Suman Bala.
Yeah. It gives me great pleasure to introduce Vignesh to this forum. Dr. Vignesh Pandirajan did his postgraduation in pediatrics from ICH Chennai, and then completed his DM in pediatric clinical immunology and rheumatology from PGI Chandigarh. He is a young guy, but wears a number of very, very exclusive hats. He's a co-chair of the APSID Juniors Working Party 2020 to 24, Indian representative for APSID Juniors 2020 to 2024, and an executive board member, North India Indian Society of Kawasaki Disease. He has about 120 publications in national and international journals to his credit. His areas of interest are primary immunodeficiency diseases, especially CGD and combined immunodeficiency disorders, and juvenile dermatomyositis. Pleasure to hear you, Vignesh. Over to you.
Thank you, ma'am. Am I audible and is my screen visible?
Yes, Vignesh.
Thank you. So thank you, organizers, for having given me this opportunity and for giving me this interesting debate between the cytokine blockade versus the HLH protocol in the management of secondary HLH. So I'll be talking in favor of cytokine blockade, being an immunologist. So just a quick summary of the etiology of HLH. The article, it says it's a spectrum of cytokine-driven immune disorders. So this slide we have been seeing for the last 3 days. The triggers could be genetic, the inflammatory disorders, autoimmune autoinflammatory disorders, and several infections, and as well as malignancies. So let me quickly dive into the etoposide. That's a key molecule used in the HLH 2004 as well as the previous 94 protocols. So if we look into the mechanism of action, so it inhibits the topoisomerase 2. So this topoisomerase 2, what it does is it creates the DNA break, and it also reseals that is necessary for moving the cell to the mitosis phase. So what does this etoposide do? It blocks the topoisomerase action. So it creates the breaks. it induces the double-stranded DNA break so that the cell doesn't go into mitosis and thereby inhibiting the cell proliferation. So this is basically the mechanism of action of etoposide. So the where does the etoposide initially came into the picture in hemophagocytic lymphohistiocytosis? The history dates back to 1980 and 1986. This formed the basis of the subsequent 94 protocol. So initially, the hemophagocytosis is thought to be an infiltrative pathology like a cancer. So that's why the chemotherapeutic regimens have been used and have been shown to have some form of benefit. So that has led to the subsequent 94 and the 2004 protocol. And subsequently, it has also been shown that it ablates, just selectively ablates the activated T cells. But one should remember that secondary HLH can occur with T-cell immunodeficiencies as well. So we have patients with severe combined immunodeficiency where the T-cell count is less than 100. They also develop features of hemophagocytic lymphohistiocytosis. So it is not just the activated T lymphocytes that play a role in the pathogenesis of hemophagocytic lymphohistiocytosis. And the most important component of etoposide is the side effect. So more than 10% of the patient, they develop leukopenia, they develop nausea, vomiting, cytopenias, alopecia, anorexia, diarrhea, leukopenia, and many patients also develop stomatitis, around 6%, and also hepatitis. So it's also a dilemma when you use etoposide in a child with HLH and subsequently the child develops hepatitis and cytopenias. You always scratch your head whether this is etoposide related or it is a ferritin related side effect. But the most important here is the development of infections related to the neutropenia. So this is the long-term follow-up of patients who were treated with the HLH 2004 protocol. So this is the mortality data that is given in this study published in Blood. So here we can see that in the initial 2 months, the mortality was seen predominantly in patients who do not have familial HLH, that is nothing but our secondary HLH. So in the first 2 months, so what if we look into the etiology of the mortality of these patients who had secondary HLH, so it's reported as septicemia, infections, and bleeding associated with treatment toxicity. So this mortality is much higher in secondary HLH compared to the primary HLH group, where the mortality is lower in the first 2 months. And the most important point to be noted here is one patient also developed acute myeloid leukemia after 2 years of receiving etoposide. So etoposide is not a drug to be taken as light. And subsequently, we have this publication from Turkey, secondary hemophagocytosis, do we need really chemotherapeutics for all patients? So this is a study which assessed 12 children with secondary HLH. And the physicians have used the less immunosuppressive therapy like steroids and IVIG and has shown an 83% survival. And in this study, where 2 patients in whom the HLH 2004 protocol has been used, both the patients have expired. So this again suggests that HLH 2004 protocol may not be the regimen to be used in secondary HLH. So over the years, we have learned the immunopathogenesis of HLH. So we know it's the CD8 T cell hyperfunction, which leads to the excess production of interferon gamma, which activates the macrophages, which initiates the positive cascade. The activated macrophages, it stimulates the CD8 T cell, which again is not able to effectively produce the granzymes to kill the antigen infected cells. In turn, it produces interferon gamma. So it is the cytokine cascade that occurs in HLH that results in the manifestation of vasculopathy, coagulopathy, organ damage, shock, hepatosplenomegaly, and hemophagocytosis. So this is a simplified version of the cartoon. So if we see the predominant cytokine produced by the defective CD8 T cell is the interferon gamma, which results in the increased macrophage activation and expansion. And this leads to the production of various pro-inflammatory cytokines, resulting in activation of the immunological cells. And so this is why this phenomenon is called the cytokine storm. So, and we can block the different steps, the different cytokines or you give the regulatory cytokines IL-10. So this is briefly reviewed in this review article. So mainly what we will be seeing is the anti-IL-1 agent, that is the anakinra canakinumab. I will not be going into details of that because Dr. Randy Cron's talk is to be followed after my talk, and he will be detailing on these medications. We have anti-IL-6 agent, that is tocilizumab, JAK inhibitors, ruxolitinib, and anti-interferon gamma, imatinib. So this is the gene expression profiling of peripheral blood mononuclear cells from children with active hemophagocytic lymphohistiocytosis. This side, the A panel, it shows the genes that are downregulated, and in the panel B, we see the genes that are upregulated. So we can see the IL signaling molecules, IL-10 signaling, and the IL-1 signaling. These are upregulated in children with hemophagocytic lymphohistiocytosis. So this is the study. Dr. Khanna also highlighted this, and I'll be just showing this slide where the beneficial effect of anakinra has been documented in secondary HLH. So this is the study by Dr. Randy Cron. So here the investigators have shown that earlier initiation of anakinra was associated with reduced mortality in these patients. And considering the underlying diagnosis, the systemic JA, the systemic juvenile idiopathic arthritis patients had the lowest mortality rate, and anakinra appears to be effective in non-malignancy associated pediatric secondary HLH when it is given early in the course and in patients with underlying rheumatic disease etiology. The other important cytokine in HLH is the interferon gamma. So I've already told this, the cytokine is produced by the CD8 cell, and this is the mice model, which shows that after the infection of the perforin deficient mice, the interferon gamma levels goes up, and this interferon gamma levels come down with the infusion of monoclonal antibody to CD8. And the authors propose that in perforin deficient CD8 T cell, it is the hyperproduction of interferon gamma that results in the subsequent downstream cytokine toxicity and hemophagocytosis in patients with perforin defect. So we have JAK inhibitors. So what is its connection with interferon gamma? So interferon gamma, it signals through these receptors. These are the interferon gamma receptors, and this receptor is coupled with JAKs and STAT. So this is how the cytokines, it acts through the cell receptors and the subsequent signaling from the receptors. So what does JAK inhibitor do? So these JAK inhibitors, it inhibits the JAK so that the cytokine signaling is blocked. So we have various JAK molecules, JAK1, JAK2, JAK3, and various interleukins, and as well as the interferon gamma, which signals through this molecule. So by blocking the JAK, you actually block the cytokine signaling. So this JAK1 and 2 inhibitor, ruxolitinib, have been extensively studied in hemophagocytic lymphohistiocytosis. So this is JAK1, JAK2 inhibitor, the paper which shows the effectiveness of this drug in a child with refractory hemophagocytic lymphohistiocytosis, even even when the disease is not in complete control with etoposide, dexamethasone, and anakinra. And this is a study from China, which shows that the use of ruxolitinib, it reduces the cumulative steroid exposure in children with secondary hemophagocytic lymphohistiocytosis. This is the follow-up study. This is the at discharge, the first month and in the second month. The red one is the control group, and the blue one is the patient group where they have used ruxolitinib, and they've shown that the corticosteroid load is reduced with the use of ruxolitinib. And this is an interesting case report where the child had acute renal injury, where they could not use etoposide, and ruxolitinib has been shown to be of benefit in these patients. So in secondary HLH, especially patients in ICU who have renal injury, this is a drug to be can be used. So this is another interferon gamma blocker. This is a direct monoclonal antibody against the interferon gamma, the imapalumab. This has also been used in children with HLH, and it's got its global approval for use in HLH in USA. Now, this is again an interesting article, published in Oxford Rheumatology. The etiologies and management of hemophagocytic lymphohistiocytosis is a time for an updated protocol and targeted treatments. So this is a study done in adults, 29 adults with HLH who met the inclusion criteria. The authors have shown that in patients where the HLH 2004 protocol have been used, they have noted increased mortality. 73% patients in whom the HLH 2004 protocol have been used have expired, and 8% had recurrence of HLH. And 14 patients were treated with targeted therapy. So these targeted therapy included steroids, tocilizumab, anakinra, intravenous immunoglobulin, cyclosporin, rituximab. And in the targeted therapy group, 93% had resolution of HLH and only 1 died. So this study clearly shows the benefit of the targeted therapy compared to the HLH 2004 protocol in patients with secondary HLH. So this is the recent recommendations for the use of etoposide-based therapy and BMT for children with HLH. So this recommendation clearly states that the value of HLH94 protocol is less known in infection-associated HLH other than EBV, and care must be taken to differentiate neutropenic bacterial sepsis from HLH. So whenever you have a secondary HLH in bacterial sepsis would always be in our back of our mind, and using a chemotherapeutic drug in that setting would be detrimental. And HLH94 protocol is not indicated for leishmaniasis or tuberculosis associated HLH. And in macrophage activation syndrome, IL-1 inhibitors represent a valuable addition to cyclosporin and corticosteroid, and HLH94 protocol is not considered as a first-line treatment. So to conclude my talk, etoposide, it carries both short and long-term side effects that are very significant, and clinically they can be detrimental. Cytokine blockade, it's an upcoming targeted therapy for HLH with fewer side effects. So I would probably consider cytokine blockade compared to HLH 2004 protocol in patients with secondary HLH. Thank you again.
Thank you, Vignesh. I think if Dr. Vasudha is ready. Yeah.
Good evening. Is my slide visible now?
Not yet.
I can share the presentation, Dr. Vasudha.
If you can share it, please.
Yeah, if you can stop screen sharing.
Okay.
Is it visible? Are the slides visible?
Yes, it's visible. Yes.
Yeah.
Okay. Good evening, everyone. I'll just move on quickly to my side of the debate. Being a hemato-oncologist, I will be trying to prove my point to using the HLH 2004-94 protocol for secondary HLH. So as we have learned from brilliant speakers over the last 3 days, HLH, CRS, MS, they are all acute and rapidly progressive disorders where the immune system is completely dysfunctional. It's a systemic disorder with cytopenias, excessive cytokine production, and hyperferritinemia. What is important to remember here is that it carries a very high mortality unless treated immediately. Next slide, please. So this is from Dr. Scott Kana's paper, and the reason I'm highlighting this, although we all know about this, in a PICU setting, it's very important to actually understand and make the right diagnosis of HLH, because your sepsis, multi-organ dysfunction, and several inflammatory disorders can present with similar features like HLH. And what is important to note is that it's a constellation of the findings and the severity of progression that is important to decide if this child has got HLH or not. So the right diagnosis is very important, because sometimes we tend to use steroids and other anti-inflammatory molecules in disorders that are not like HLH, for example, in sepsis and MODS, and unfortunately lose the battle. Next slide, please. You could go to the next slide. Yeah, again, we do know that there are two distinct entities traditionally, primary and secondary HLH. Primary being the ones that carry the genetic mutations, familial and secondary being the ones that are secondary to viral infections, malignancies, your rheumatological disorders, and other infections like tuberculosis and leishmaniasis. Next slide, please. But what we need to remember, and what I would like to highlight, is that both primary HLH and secondary HLH are triggered by infections. And there's a significant overlap in the phenotype and severity between primary and secondary HLHs. And like we have learned over yesterday by Dr. Claudia, heterozygous mutations have poorer outcomes with severe phenotypes, and they do have recurrences. And younger age is again a big confounding factor. In a child with a younger age, it is a high probability of having a primary HLH and may be mistaken to have a secondary HLH. So before I would like to try and tell you the facts of secondary HLH or primary HLH treatment, we do need to ask always that, next slide please, how sure are we that this is a secondary HLH, which is a very, very, a big confounding factor in the Indian scenario, because we need to actually wait for genetic tests, degranulation assays to be sure if we are dealing with a primary or a secondary HLH. Next slide. This is an excellent review in the NEGM, which actually shows us the downstream, the pathogenesis, pathophysiology of a cytokine storm. But if you could see the topmost upper right corner, we have got the driver cells which come into action in the outset of either an infection or iatrogenic causes like CAR T-cell therapy, or with an underlying monogenic and autoimmune disorder. And they drive the entire, downstream cytokine storm, thus causing the acute inflammatory effects and the organ damage. So I am fighting a contention for actually removing the source of these cytokine storm, which is targeting the T cells, and thereby avoiding the entire downward cascade, which exactly is what the HLH 2004 or the 94 protocol does. Next slide. And even in this entire, there is a beautiful chart about the different types of cytokines released with the different etiologies. And the most commonly seen one, for example, the primary HLH, secondary HLH, MAS, as well as the EBV-driven HLH, you can see that the CD8 cells are the main players. They drive the entire inflammatory cascade. So why cannot we target the CD8 cells, which are the source of these cytokines, instead of going downstream? Next slide. So with that, I'll come to the HLH 2004 protocol. So the HLH 2004 protocol essentially has 3 drugs: the Dexamethasone, which is the steroid, the etoposide, and cyclosporin. Intrathecal therapy may or may not be used. With these 3 in mind, the entire treatment is propagated. But the first thing that I'd like to point out is whether it is a primary HLH or a secondary HLH, steroids are our go-to drugs. Next slide, please. So there is a modification of the HLH 94 protocol, because the cyclosporin upfront usage did not give us any, specific significant advantage. So this is a kind of a suggestion by El et al., including Dr. Hunter's group, which says that cyclosporin may be introduced 2 weeks later. And the initial therapy, the 2008 consensus recommendation, comprises of steroid, dexamethasone, etoposide, again the dose and duration, I will come to it, and intrathecal therapy only if the patient requires it and does not respond to the initial systemic therapy. Next slide. And of course, treat underlying triggers is a main part in secondary HLH. Next slide, please. So all these drugs, the steroids, etoposide, and cyclosporin A, mainly cause cell death in activated T cells, macrophages, and dendritic cells. From Dr. Hunter's talk, we understood the mechanism of etoposide so well. It is not just a chemotherapeutic agent. It induces pro-apoptotic cell death of activated T cells and macrophages and dendritic cells. And in EBV-driven HLH, the outcomes of etoposide are so good. Even before the use of rituximab, etoposide use in EBV-driven HLH gave very good outcomes. And cyclosporin A also causes reduced activation and proliferation of T cells. It may be used for preventing a recurrence of the HLH. Next slide. So why are we, if HLH 94 is really good, then why are we actually doubting it? So there are doubts on the efficacy of the treatment, the indication, primary versus secondary, the duration, and the toxicity and side effects, which I'll be addressing in the next slides. Next slide, please. So with regards to the efficacy, this is the largest study done for all HLH patients, the HLH 2004 study, which recruited 369 patients. And with the HLH 94 study, there are about 700 patients, which is the largest cohort for such a rare disorder. And you can see the efficacy of the entire regimen, which shows about 61% 5-year progression-free survival. And for those which were not verified familial HLH, this is for the overall cohort, the plot A. The second one with the not verified familial HLHs had a 64% 5-year progression-free survival. Next slide, please. So mind you, in this cohort of 369 patients, there were 168 patients with verified familial HLH, and the rest of them were treated as a secondary HLH. So this trial had included both patients with primary and secondary HLH. Next slide, please. And coming to etoposide, so what is the efficacy of etoposide? Is it only for primary HLH? So again, this is like Dr. Vignesh showed as a recommendation for the use of etoposide-based therapy, and it can be used both in primary HLH as well as severe secondary HLH. So what do we need to understand before we use etoposide? Next slide, please. So does it have to be followed as per textbook, as per guidelines? So can it be individualized? With this, Dr. Jan Inge's talk gave a fantastic actually through light on this. It depends on the clinical context, the underlying condition, the age, the severity of the HLH. So of course, like I said, steroids are our go-to drugs for any kind of HLH, primary versus secondary. In fact, even in studies that have used cytokine blockade, most of them have used it with steroids and not by themselves. If you have a secondary HLH with a milder clinical course, there is no need to use a twice weekly etoposide to start with. You can use a once weekly etoposide. And in fact, you can use reduced dose etoposide to older teenagers and adults who you think would not tolerate it. And HLH 94 or 2004 does not mean that you have to use 8 weeks of etoposide. You can stop it if you see clinical improvement in your patient, by the time of which you would have got your genetic studies and understood whether this is a primary HLH, do you need to continue, or the secondary HLH, you can stop. And I would like to dispute the fact that Dr. Vignesh said, in fact, etoposide can also be used in hepatic dysfunction. Hepatic dysfunction is not a contraindication for using etoposide. Next slide, please. What about cyclosporin A? Everyone is nervous about cyclosporin A, nephrotoxicity, press, and things like that. So yes, do not use cyclosporin A in the first 2 weeks with dexamethasone for severe risk of press. Early addition has not been beneficial seen by the HLH 2004 trial. It is a bridge to stem cell transplant, prevents reactivation. And a point to be borne is, in contrast to what is mentioned in the trial, lower trough levels, about 120 to 150 milligram per liter, help to minimize toxicity. Next slide, please. And what about CNS directed therapy? Does every child need it? What if it's a secondary HLH? Do we have to subject them to an intrathecal methotrexate? Not necessarily, because even in the protocol, intrathecal methotrexate comes only after 2 weeks of systemic therapy. And by these 2 weeks, because of the good penetration of dexamethasone, most of the CNS symptoms would have improved. Next slide. Okay, so what about the third part, the potential toxicity of treatment? So definitely, yes, the syndrome of immune dysfunction itself, ongoing viral infections, steroids do kind of predispose the patient. So you need to start the patients on antifungal prophylaxis and pneumocystis jirovecii prophylaxis. The risk of AML, like my colleague pointed out, is much lower as compared to the morbidity and mortality associated with severe HLH. So in the HLH 2004, we had a morbidity of 40%, and 20% of them were before a stem cell transplant. And this patient who developed was a one patient in those 369 patients. So it's about 0.3% incidence of acute myeloid leukemia. Next slide, please. So why not cytokines? Why am I arguing for the HLH protocols? So like we have seen with all our previous speakers, there is excessive production of a large number of cytokines in hemophagocytic lymphohistiocytosis. There are different patterns of expression in, for example, in primary HLH, secondary HLH, that due to SOGIA, that due to SLE, etc. So will blockade of a single cytokine help? And this cytokine blockade does not again remove or impact the source of cytokine production. Circulating cytokines can be difficult to measure, and the real world scenario is the availability of the cytokine blockade and the cost. Next slide, please. So my conclusions are HLH is potentially fatal if not treated soon. So do we wait to procure the cytokines, or do we start off with the DEXA, and then if the child does not respond, go on to etoposide, maybe in a dose modified pattern? There's considerable overlap in the phenotype and severity of primary and HLH and secondary HLH. So always bear caution in our setting. Steroids are the cornerstone of HLH treatment, which is included in the HLH 2004-94 protocols. Clinical trials, lack of them, availability, and cost limit the use of cytokine blockade at present. I will leave you with a case scenario. This is a 6-year-old boy who presented to us previously absolutely well, who presented to us with fever of 10 days. There is periorbital edema and abdominal fullness since 3 days. On examination, he had pallor and a huge spleen. On an evaluation, he had a low hemoglobin, platelets were borderline, and the WBC count was also low. So he was admitted and started on empirical broad spectrum antibiotics, evaluated for infection. However, the very next day, deteriorated, developed hypotension with tachycardia, altered sensorium, shifted to the ICU. This is a typical child that we are talking about for this case. And repeat evaluation showed that all his counts had dropped. The ferritin was 9,800. So what do we do in this case? I would start on steroids, to be frank. This is a child who's really, really sick. I cannot afford to have any delay for him. So he was started on the HLH 94 protocol, and although his age was not so typical, we found that he had a compound heterozygous mutation in the UNC13 gene, and unfortunately had a relapse during the continuation therapy, a CNS relapse, and he received salvage therapy and went on to receive HSCT. The point of this case is that, yes, we do see a lot of compound heterozygotes, lot of genomic polymorphisms in our cohort. So we need to be really careful before labeling anyone as primary or secondary HLH. And HLH 2004 or 94 protocol, albeit with modifications, would be the safest and the best available therapy for all of us, at least in our setting at the moment. Next slide, please. And I would like to give credit to Dr. Scott Kana. He kind of helped me out for my last slide. And yes, this is the last slide. And I would like to draw your attention to the last chart. Next slide, please. Can you please press? Yeah, so someday, definitely, even I hope that we do have cytokine blockade as the first line kind of therapy for secondary HLH. But for now, we are not yet there. Thank you so much.
Well, I think this debate is hotting up nicely. I like the passion in both the debaters. We'll give them, I think, 2 minutes each to do a rebuttal. Vignesh, you go first.
Yeah, thank you, Dr. Vasudha, for the interesting talk. So I think the data is more towards the management of primary HLH, which Dr. Vasudha has talked about. Whereas in secondary HLH, it is the most of the times it is the treatment of the underlying trigger with steroids, and IVIG does the major part of the work. But in some cases where the HLH is lingering on, so in those cases, I think therapy which is less invasive, less chemotoxic drug, either in form of a cyclosporin or in form of cytokine inhibitors, would be preferable compared to a chemotoxic drug like etoposide, which has a lot of complications. And of course, if you have to block CD T cells, I think Dr. Randy Cron has commented, why can't you just give cyclophosphamide instead of just going with etoposide? And coming on to the point of the selective depletion of activated lymphocytes in etoposide, it's a good study, but I would like to place an argument that even patients with T-cell immunodeficiencies have been shown to have HLH. So it is not just, I presume it's not just the activated T cells that is resulting in HLH. That could be a component of innate immune activation as well. Thank you.
Thank you, Vignesh. Dr. Vasudha?
Yes, ma'am. Thank you. So I did address Dr. Vignesh a few points in my talk as well. I would like to say that cyclosporin is not going to act immediately. It's going to take time to act. And if we make modifications, even for dexamethasone, 10 milligram per meter squared is a really high dose of dexa. There are anecdotal reports which have used much lesser doses, maybe 6 milligram per meter squared. And then as soon as you get your response, you need to start tapering it down. So the point I would like to make is you don't have to go the whole length of the HLH protocol, but starting with something, especially when availability of the cytokine blockade is a real issue with us. I think that's a really good way forward, balancing, of course, the toxicities of dexa and etoposide. And I think I would like to end there.
I think that's been a fantastic debate. And I don't know, Chandrika is trying to set up if we can do a show of hands so that we can see which way people have been swayed. From my point of view, I think what this debate shows us, it shows us options. It shows us the way to think through HLH, think through the different causes, think through what are the options you can advise for that clinical scenario and according to what's available to you. So both speakers have made their points and both speakers have actually given us options in our armamentarium. Thank you very much. It was delightful. And we'll move over to the next session.
Thank you.
So thank you, Dr. Suma and Dr. Arun for chairing the previous session, and to all the speakers for a wonderful session and start to day 3. With this, we'll move on to our next session, for which I would like to invite our chairpersons, Dr. Jayashree and Dr. Jagdish Chinnappa. So Dr. Jayashree is the Professor and Chief of Emergency and Intensive Care Services at PGI Chandigarh. She has been the past Asian representative of World Federation of Pediatric Intensive and Critical Care Societies, and she's currently the chairperson of the COVID Management Committee. Welcome, ma'am. And Dr. Jagdish Chinnappa is the cluster head of pediatrics at Manipal Hospitals, Bangalore. He's been the past president of the respiratory chapter of Indian Academy of Pediatrics, and he's also a consultant at Child Central Bangalore and the CEO of Bangalore Medtrain LLP. Welcome, sir, and over to both of you for the next session.
A very good evening to all of you. And thank you, Dr. Chandrika and Dr. Akshay, for this wonderful conference. I would just like to confirm if I'm audible.
Yes, you're audible, ma'am.
Yeah, okay. So thank you, Chandrika and Akshay, for this wonderful conference, and really a topic which is out of the box and probably very topical now that we are going through the COVID pandemic. And it's a great pleasure to co-chair with Dr. Jagdish Chinnappa. It gives me great pleasure to introduce the first speaker for the next session, and that's Dr. Akshay. Dr. Akshay is currently the head of Pediatric Intensive Care Services, academic director, Department of Pediatrics at the Rainbow Children's Hospital, Bangalore, and he's currently the president of the PediStars India. Now, PediStars is a very popular name. It is involved with simulation training all over the country, and Dr. Akshay has been instrumental in taking this to several corners of the country. He's the president and founder member of PediStars India. He's also a visiting professor for the CHOP Children's Hospital of Philadelphia. He was awarded the fellowship in point of care ultrasound by the American Ultrasound Leadership Academy. He has conceived and conducted simulation workshops across the country. He has multiple publications both in international and national journals. And I know that Rakshay is very passionate about certain areas, most important being simulation, critical care sonography. So ultrasound is again something which is very close to his heart, and critical care physiology. On a personal note, it really gives me a lot of pride, pleasure, happiness, and fulfillment to do this job of introducing Rakshay to this August gathering. It's been a very long, cherished association with Rakshay ever since his PGI days. And he's going to be talking on a topic which is very, very crucial for all intensivists come the tropical season. And we know that how scared we get of the severe dengue that we see. Last year, post the second wave of the COVID pandemic, we really had a very bad wave of dengue and severe dengue. And as the disease has evolved over the years, so has our learning. So, as intensivists, we have now started thinking about more things in dengue other than fluids and vasoactive. So, the cytokine release syndrome that we have been listening to, does that apply in dengue too? Can we explain the multi-system manifestations because of CRS? And if so, do we have some immunomodulation in our armamentarium? That's what Rakshay is going to throw light on in the next 20 minutes. So the stage is all yours, Rakshay. We are eagerly waiting to listen to you.
Thank you so much, ma'am. Thank you very much for your very kind introduction. Is my slide visible?
Rakshay, you need to put it on full screen.
You put it on full screen, yeah.
It's on full screen, so it's not visible?
No, it's just a Gmail shot that is visible. Am I right?
Yes, ma'am.
Yeah.
Let me close everything.
As Rakshay is trying to put his slides on slideshow, for all the participants and delegates, if you could keep putting your questions in the chat box, that could save a lot of time at the end of the session for the interactive discussion.
Is this visible now?
Yes.
Yeah, yes, it is.
Thank you so much. Thank you so much, madam, for a very kind introduction. So I'm going to talk about a topic in severe dengue. Do we think there's a role for immunomodulation? So this talk, I'm going to phase it in a way that let's try to understand what happens in severe dengue. What do we know currently about immunopathology of the critical phase? Is there an opportunity to immunomodulate? How do we manage hyperferritinemic sepsis we commonly observe in severe dengue? And also, we started doing a bit of immunomodulation in our unit, and I'll share a bit of an experience. So this is going to be more of an explorative talk rather than a recommendation. So it's going to look at what is available currently in terms of evidence, how can we interpret it, and is there a way in terms of improving outcomes of these very, very sick children? So we all know that unfortunately our country kind of keeps seeing outbursts of dengue almost every year or every other year. And same happens in certain other parts of the country. But it seems like most of Southeast Asia do get affected. And what we know is it's one of the leading causes for death, at least in the tertiary care PICUs. Like what Madam said, it's incredibly painful to see children coming and just dying in a matter of few hours. And some of them we struggle for a day and then we lose them. And what we also know is younger children seem to be significantly at higher risk of dying because of severe dengue. This is a diagram I'm sure most of the intensivists and pediatricians are very familiar, but nonetheless, considering that we have a multidisciplinary crowd, let me go through this bit carefully because this is an important slide. Now, what we know is that these children tend to have fever for 4 to 5 days. And this fever coincides with viremic phase. Okay, so there is significant amount of viral load in the blood. And many times we use NS1 antigen, one of the non-structural proteins of dengue, to identify dengue fever. And then we enter into critical phase, and that coincides with viral load coming down to almost zero. You don't detect NS1 antigen, and your serology becomes positive. It starts with IgM response and subsequently IgG response. Now, almost never you would see a patient in febrile phase landing up in severe dengue. It almost always coincides with the critical phase. And what we see this critical phase is that it lasts for 2 days. And what is the nature of that critical phase? We see significant amount of vascular leakage and seeping, developing third spacing. They develop narrow pulse pressure, and they come with profound shock. And many times, if they decide not to get better, they'll end up developing liver failure or bleeding, and you lose the patient. Generally, around 48 72 hours later, there's a phase of reabsorption, which means the fluid which has gone into third space gets reabsorbed back. And that's also a period where you could lose a patient because of massive pulmonary edema. So both this critical phase and reabsorption phase are a problem. And hence we're in a dilemma, because if you give too much of fluids during critical phase, you land up with trouble of reabsorption phase and its consequences. So this is a general framework of how a dengue fever behaves. Now, WHO has classified this. So what we can see here is they've classified into mild, moderate, and severe dengue. And the mild dengue is just an undifferentiated fever. The moderate dengue generally deals with dengue in high-risk groups like infants or someone with underlying comorbidities, or you have a leakage which is not significant enough, or you have minor bleeds. And the leaking here is present, but it is not affecting your hemodynamics. A severe dengue is the one where the leaking is affecting our hemodynamics, the bleeding is affecting you because it's significant, or there's a presence of end organ dysfunction, a direct involvement of an organ. So that is the severe dengue we are talking about, and that's a segment of patient we are quite interested in, because those are the ones who come to ICU and lose their life. Now, what we know about mortality and this whole spectrum of severe dengue is that roughly around 30% of them do land up in severe dengue. 70% of them don't. In that 30%, roughly around 30% do develop shock. Okay. Now, when we look at why patients die, what we can go understand from these studies is that those who are very sick, needing vasopressor support, who are high PRISM score, significant positive balance, and presence of end organ dysfunction, they seem to die. And that's the reason how patients die because of dengue. And one of them is the liver. And this liver is one of the most important causes for dying, and the mortality is extremely high if they develop a fulminant hepatic failure. And this is something I think most of the intensivists who work in our country see this, we dread this. You develop fulminant hepatic failure in dengue, that's almost an end game. There's very, very little what you can do. Now, there was a very interesting talk by Dr. Pooja Mehta on day one, and she spoke about how they thought about immunomodulation in COVID. Interestingly, she said, when they looked at interleukin-6 levels, it was far lesser in COVID compared to other conditions like sepsis. But then, when they did a bronchoalveolar lavage, they found the inflammatory markers were very high. So it was considered as a localized inflammation of the lung. And that's how the whole therapy with regards to DEXA came into fore. Now, if you try to look what actually happens in the liver, it's quite interesting. You don't see much of inflammation, but what you actually see is a lot of apoptosis. So it's not like a lung, what you see in COVID, where there's inflammation, but you see more of apoptosis. But obviously that apoptosis gets triggered by something else, and probably there's a lot of cytokine role in triggering this apoptosis in liver. Now let's understand a little bit about how it works. So essentially in our body, the dengue exists in three forms: a mature form, which is very smooth, and an immature form, and a partially mature form. So essentially you have three structural proteins, of which you have envelope protein, capsular protein, as well as precursor membrane protein. The E protein, because all of us now know about COVID, we know there's a spike protein through which you enter the cell. In dengue, it's the envelope protein through which you enter the cell. Then there are around 7 non-structural proteins, of which non-structural protein 1 we use for diagnosis. So it essentially helps with replication. Now, why I'm saying this is the infected form is actually the complete form. The partially mature forms also can be mature. So these spikes, what you see on the surface, are because of precursor membrane proteins. If they don't get cleared properly, you'll end up having few spikes. There's a bit of importance to that in next few slides. So now let's try to understand what is the pathophysiology. Why is that they leak so much? Do cytokines have a role? Now, unfortunately, this is a study that people have tried doing. It's very patchy, not very well described. And unfortunately, there's a lot of limitations and difficulty, because if you were to look into the studies of cytokines, it depends on which phase do you do. Do you do in a febrile phase? Have you done it in a critical phase? Or have you done in a phase where there's already end organ dysfunction? That all will change the kind of interleukin profile you would see in them. And also, how much time does it take for you to process? And unfortunately, many of the studies do not have a correct description of the clinical situation. So that makes it interpreting a bit difficult. But nonetheless, we have some amount of insights. Another unfortunate part about dengue is that we don't have a good animal model which can exactly replicate humans' dengue behavior. And that again further limits its pathophysiological understanding. Many times we just have to rely a lot on clinical studies. So what is it we know? We know that once there's a mosquito bite, there's a local response with dendrites as well as mast cells. What people have studied is when they have seen that in dengue fever who land up having severe dengue, there is an excessive mast cell, the mast cell response does not seem to be that great. There is a huge amount of kinase release. What we know subsequently is these dendritic cells carry these viruses, they go to lymph nodes, and then subsequently adaptive immune response starts. Now, what we know now very clearly is 15 to 20-fold rise happens in severe dengue or dengue hemorrhagic fever when it's a secondary infection. The primary infection causing severe illness is a rare event, whereas almost always they tend to be because of secondary infection. Why does it happen? So there are two reasons which have been hypothesized. One is because of T lymphocytes, another one is because of antibody-dependent enhancement. Now, what happens with T lymphocytes is there are a lot of study done under understanding cytotoxic T cells. Now, there is some concept of original sin, which has been understood quite well in Haemophilus influenza. A similar kind of thing seems to be happening because the CD8 cytotoxic T cells, which comes as a response to a primary dengue fever, it doesn't seem to be doing a good job for other serotypes. With other serotypes, it seems the degranulation and killing of that cells is ineffective. Instead, it seems to release a lot of inflammatory mediators. That's what has been observed. And unfortunately, the antibodies also, when the antibodies are produced against envelope proteins and these precursor membrane proteins, instead of killing them, it seems to be promoting their engulfment into the monocytes. Monocytes seems to be cleaving these precursor member proteins and making them more active virus, thereby increasing the viral load. So that's what seems to be happening. And what they have understood in the critical phase when they looked at interleukin, it appears like tumor necrosis factor alpha and VEGF-A. These two seem to be at a much more higher level in those who leak. And there's a description in terms of animal models too, to show that they can increase vascular endothelial leaking. Now, what is very important to understand is this is very much unlike other disease. Here, what we're seeing is we're seeing a leaking which lasts for 48 hours to 72 hours, and then the reabsorption starts, which means you don't have a direct damage to the endothelium. If at all there were to be direct damage to vascular endothelium, you cannot have a reversal of this entire leaking within a span of 48 to 72 hours. So it has to be mediated by some amount of local cytokine release. Of course, there are some studies looking at NS1 antigen directly damaging the glycocalyx membrane and increasing the leaking. But then again, it begs the question that NS1 antigen levels is very high during the febrile phase, not during the critical phase. So that is something people have struggled to understand. So what we know now is TNF alpha and VEGF, they seem to have a significant prominent role during the vascular leakage. Now, this is a slide which again Dr. Ronco showed. This is based on sepsis model. And why this is important is to understand that when we look at the interleukin release 2, there is a significant amount of interleukin 10 release. And that is again dependent upon your regulatory T cells. And what does interleukin 10 do? It wants to decrease the amount of inflammation caused, hence it gets released. And during the critical phase, the level goes up very high. So there is a phase where there's enhanced inflammation. At the same time, there's also a phase of counter of interleukin 10 release, which tries to limit the damage. Now, if it can limit the damage, it is fine. But what happens, unfortunately, at times is this anti-inflammatory phase can become extremely prolonged. And why I'm saying this is because when we look at immunomodulation therapy, and I think it's very important for us to think in terms of achieving immunohomeostasis, in the sense that not really thinking of only counteracting hyperinflammation and trying to give those drugs which can potentially enhance the anti-inflammatory phase. Because if you push the patient to the other end and try in the process of abolishing the inflammation, you are at a risk of having a severe anti-inflammatory state, an immunoparalyzed state, which significantly increases the chance of bacterial infections, fungal infections, viral infections, and that can lead to death. So that is very important for us to understand that IL-10 levels do go up, and it can significantly, it's a phase where there's both hyperinflammation as well as immunoparalysis, which seem to coexist. Now, this is a very good paper if we were to read, and it looks at how do we, what's the difference between hyperferritemic sepsis versus bacterial sepsis. Now, what we know here is in hyperferritemic sepsis because of dengue, the leaking is a significant amount of problem. There's too much of fluid loss, severe hemoconcentration. We don't see that kind of water loss or vascular leakage in septic shock because of bacteria. What we see is more of vasoparalysis. The way the organ gets involved is also very different. The lung seems to be the predominant organ which gets involved in its multi-organ dysfunction syndrome, whereas it's a liver which seems to be the more prominent organ when it comes to dengue. And also, when the kidney gets affected, acute tubular necrosis is a more dominant in septic shock because of bacteria, whereas mesangial proliferation seems to be the more prominent mechanism. Glomerular injuries appears to be the more prominent mechanism in the kidney. So the dynamics where the lung gets affected also is quite different in dengue compared to compared to what happens in septic, because you see more of alveolitis and ARDS. Here you see more of pulmonary hemorrhage as its dominant manifestation. What we also see is completely normal CRP, whereas we see very high CRP. We see disproportionately very high ferritin levels. We don't see that high levels in regular septic shock. And the interesting thing I have already just mentioned is the way the vascular leakage reverses in 48 hours, which does not happen in septic shock. Another interesting thing is you see more of thrombotic complications. In fact, one of the phenotypes described in Dr. Joe Carcillo's article about thrombocytopenia associated multi-organ failure, they have a lot of thrombotic complications, thrombotic microangiopathy. There's a microvascular thrombosis which causes a lot of problem. Whereas here in dengue, it's a bleeding which causes a problem. Thrombosis is not much of an issue. So that's kind of a difference in how dengue shock behaves differently compared to a bacterial septic shock. Now, what is it we know? What we know is that WHO had come up with a protocol, and it's heavily dependent on the fluid based on a simple fact that this is a 48-hour self-limited process of vascular leakage. So you replace fluids, maintain your hemodynamics, ensure there's a reasonable amount of organ perfusion, and once the vascular and wait till the vascular leakage stops, and then let the the fluid reabsorption starts and things go back to normal. Many of us in intensive care practice have figured out different ways of giving these fluids in a combination of colloid crystalloid, because we don't want a reabsorption phase to get worse, because you give too much of fluids and the patient can actually die because of too much of fluids. Now, this we know works really, really well. In fact, it significantly improves the outcome. Patients do come out of it. But the problem happens is like what Dr. Jayashree mentioned. When these patients come, they come in heaps and bounds. It's unfortunate that there's so much of focus on COVID and nobody focused on dengue. And we see this every year. There is limited pediatric ICU beds. It comes in the paper, comes in the newspaper, but it's not very glamorous like COVID. So it doesn't really gain a lot of public attention. But we see these people just roam around trying to figure out a bed. The greatest difficulty in dengue is you really don't know who lands up in this critical phase. And what we know is once you land up in critical phase, finding a bed in ICU is incredibly hard. And we know that fluid therapy works. But the problem is, if you don't give fluid therapy in a timely fashion, you land up in trouble. Because the moment even few hours delay, we have seen, and this is something we hear very commonly. The child was talking today morning, and I can't believe that child is, you're saying the child is very sick, and by night the child is dead. It's that shocking and disturbing even for us as clinicians. And also it's unpredictability in terms of whose liver gets affected, whose brain gets affected. That is something we just don't know. And what we hope as clinicians, as intensivists, is that we hope that it does not leak. Another frustrating part is because of this anxiety, many parents get admitted on day 3, day 4. And they get very frustrated with the fact that the child is admitted in the hospital. And you're saying that child was okay. On 2nd day, 3rd day, you're saying the child is extremely sick now, leaking, and possibly there's a chance of dying. That's something parents find it very, very hard. So if you were to think of this, there is 2 scopes for us as clinicians. One is, can we really stop this critical phase and altogether? And if we cannot, and in those patients who develop organ dysfunction, is there anything else we can do? Because clearly what we know is someone who develops liver dysfunction and has a progressive liver failure, no amount of treatment in terms of fluid therapy is going to work. So this is where I think we could have, one good thing which came out of COVID is its immunotherapy. And if you look at the course of how the COVID behaves, in many ways, it has some amount of similarity with dengue. You have this phase of viral response phase and the host response phase. And we see that initial first 5 days of illness, first week of illness is a viremic phase. And second week of illness is the immune phase. And that's the reason the timing of steroids became very important. In fact, when we talk about treatment of COVID, we say remdesivir, monoclonal antibodies in the first 1 week. We talk about using steroids and the timing of steroids being very, very critical here. And it has saved countless number of lives by preventing those patients, identifying those patients in hyperinflammatory phase very early and intervening. The question for us is that something we can do here? Is there a phase where like dexamethasone, like a recovery trial, where it gives steroids at a correct time and prevent these patients? Because when an outbreak happens, it's really difficult to find bed. These patients really suffer. It takes a few hours of being in leaking phase is enough to take your life away. So there have been some studies which have been done, which looking at antivirals like remdesivir. There's a study done in Singapore looking at balaparavir. There is a study done in Vietnam looking at selgasavir. Both were randomized controlled trials. They couldn't find any benefit in those trials. So second comes is immunomodulation to prevent the critical phase. Let's look into that. What studies we have. So there are some studies which have been done. What steroid role in dengue has been studied in 3 phases. One in that febrile phase, in the viremic phase. These are all the various studies what have been mentioned. These studies have been done in last 10 years or so. They haven't shown much of a difference. They did what they showed was using steroid was not very harmful, but there was no benefit seen in terms of preventing a patient from entering into leaking phase. Now, this is a study done at the onset of critical phase before they landed up in grade 3, grade 4 dengue, severe dengue. So they are in critical phase, but they're in moderate disease, but they're not in severe disease. So that's the category of patient they targeted. Now, it's a very interesting to see that a lot of these studies, especially the last 2 studies, have been done in 1980s. Only the Fernando study was done in 2015 or so, but a lot of these studies are done in 1993, 1994. It's pretty old studies. And actually, if you look at these studies, it's quite interesting that it shows that steroid is actually beneficial when used in this time frame. Almost all of the studies which I have mentioned include the latest study done by Fernando group. Some of them have used hydrocortisone, some of them have used methylprednisolone, but they have shown consistently that there is a benefit. So there is a signal here to say that probably there are groups that if you use steroids correctly in a correct time, there could be a benefit. This is a study where you have gone into an advanced disease. There's already an end organ. We're talking about late phase. Unfortunately, these studies are done in 1975, 1983. There's only Premaratna study which has been done bit recently. But otherwise, these are very old studies. And they did not show much of a benefit. Again, it's very hard to interpret because you need a good intensive care when you reach a critical phase of this kind for any immunotherapy to work. So it's very difficult to interpret this particular evidence. Having said that, we heard in COVID times, ivermectin, we heard about hydroxychloroquine. There's a lot of craze around this. And in fact, there have been studies done of similar kind in dengue too. There is an RCT done on chloroquine. And this was given in first 3 days. And they wanted to look at the antigenemia, decreasing the antigen burden. They didn't find much of a difference. There was also a study done on a lovastatin. Again, first 3 days to look at the antigen levels to see if the antigen levels come down. Again, they could not find much of a difference. There has been a very old study done on IVIG, but they had a wrong endpoint. They want to address thrombocytopenia. In fact, initial studies, people thought thrombocytopenia is a big problem. They wanted to sort out thrombocytopenia, and a lot of therapies were addressed towards decreasing thrombocytopenia. So now it appears like in the critical phase, there might be a role for moderate disease for steroids, but then I think we need a very well conducted study to address this particular issue, and that can probably do a lot of good if it works. But right now we are faced up with conditions where a patient comes to ICU and has end organ dysfunction. So what do we do? What we know in all these patients, and because we started doing ferritin now more often, that many of these patients have severe hyperferritinemia. So we heard a lot about ferritin last couple of days, and we know that it exists in 2 forms, the H form and L type. The idea behind the ferritin is it wants to bind ferritin so that this free iron inside the cell can damage DNA. So their number goes up because if the free hemoglobin goes up, the ferritin does go up to protect the internal DNA. It exists in heavy chain and L chain. L chain is iron poor form, and the heavy chain is one thing which is really helpful to our body. Now, the interesting thing is ferritin just a biomarker of the severity of illness, or does ferritin by itself cause you more injury? And there are some emerging evidence to say that it can do it. It can be both an immunosuppressant and a pro-inflammatory and cause progression of liver injury especially. Now, why are we worried about ferritin? And this, again, we've heard a lot of these evidences over the last couple of days in Dr. Joe Carcelo's article. And this particular study, I think, has been quoted by almost every speaker in the last 2 days about the role of ferritin. See, this is something, many of us probably are not very seriously, including myself in our own unit, that levels about 10,000, there's almost only one differential diagnosis, and that is HLH. And this is what this study showed, that moment it crosses 10,000, that is a kind of a point of no return. So it's a pathologically very highly elevated ferritin, and without intervention, those patients don't do well. In fact, in this study, they noticed that presence of fever does increase its sensitivity very high. And also there was a mean rise of around 1000 of ferritin every day. So when people looked into ferritin levels in severe sepsis and septic shock, they came up with this result where ferritin response, if it is poor, the outcomes were poor, which means you need some amount of raised ferritin to have a good outcome. And they found that this good outcome happens if the ferritin response is between 200 to 500, possibly because, like I just mentioned, because when there's a lot of free hemoglobin, some amount of good ferritin has to go up because it has to stop binding this iron, because it causes significant amount of oxidative stress to DNA. So might be that's why it goes up. And they notice that in presence of bacterial sepsis, if the ferritin level does go more than 500, then it's pretty dangerous. And this is again a study that they noticed that above 3000, you don't have to wait till 10,000. Even if it crosses 3000, those outcomes are not great. In fact, once it crosses 1000, there's a sequential rise in mortality. Now, this is an excellent paper. Again, Dr. Joe Carcelo did go through this. And this is a really good model for us to understand how ferritin could be damaging. Now, what happens here is there is a rise in free hemoglobin. Now, whether that happens because of hemolysis, whether it's because of dying red cells. Now, these free hemoglobin seems to be acting on CD163 receptor. They get internalized, and this free hemoglobin increases the production of ferritin inside the macrophage. At the same time, what happens is these viral DNAs for a DNA virus or any other viral particles or in the form of DAMPs, they activate Toll-like receptors 9. And what it does is it promotes inflammasome formation, which increases interleukin 18 as well as interleukin 1 production. And that itself again significantly drives ferritin production. So ferritin production can happen by two ways. One, by your dying red blood cells or hemolyzing red cells. Free hemoglobin drives up ferritin production. Other way is the viral particles itself by Toll-like receptor increasing the ferritin production. Now what happens finally is that you have very high ferritin production. Like I said, they have both pro-inflammatory as well as anti-inflammatory effects. They have a significant anti-inflammatory effects because it increases the production of IL-10, it decreases movement of B lymphocytes, produces energy, and decreases antibody production. So this is important because ferritin probably by itself has an immunosuppressant effect and potentially can increase the chances of getting secondary bacterial infection. Now, this model is also very interesting because it helps you to understand how we can intervene there. Free hemoglobin could actually be decreased by doing plasmapheresis. By giving IVIG, you could probably interfere by preventing the DAMs from attaching to the TLR receptors. And the interleukin 1 receptor antagonist, anakinra, we spoke a lot about it yesterday too. That could potentially inhibit the ferritin production and from ferritin going up very high. So that's how the working model is and helps us to understand. Now, the beauty about this model also is that, we heard about how cytotoxic T cells, they increase the production of the ferritin through macrophages. But what they found out in virus particles, you don't have to go through T lymphocytes at all. You don't have to go through cytotoxic T cells, but direct activation of macrophage through this mechanism itself is enough for you to increase the ferritin production. Now, other very interesting study is this animal study. And what they found out in this animal study is that for the ferritin levels to really go up too high, there's a two kind of insults. First insult happens through a virus. Second insult happens through bacteria. So if you start with a viral infection first, and then you have bacterial infection second, that seems to be a lethal combination. It can drive up ferritin levels to crazy. So this is what an animal study showed. Now, do we have a clinical study? This is so much for mice, but do we have any clinical data? Now, this is a study done in humans, and where they found is that the lipopolysaccharide levels go up in those who are very, very sick. So if you can see this study, and they do very poorly. So combination of bacterial sepsis plus in the phase of dengue, it has to happen first virus and then a bacteria. That combination seems to be quite lethal. And unfortunately, what also happens because of this leaking phase, probably there's some gut leaking, and there's a lot of gut translocation which can happen, which can act as a secondary insult, and that can seem to drive ferritin levels very, very high. And again, this study, a few more adult studies have looked into it, And they found out that when there's a concurrent bacteremia, when they come to the hospital with both bacterial sepsis and dengue, their outcomes are very poor. They don't seem to do quite well. Now, this is again a study which Dr. Joe Carcillo showed, a very interesting combination where they used both biomarkers of CRP and ferritin. And what they found out is there's a very high risk for mortality when the ferritin level goes up above 373 and CRP of 70 milligrams per liter. Combination of these two seems to actually worsen the outcome. So it sounds like when both go up, ferritin and CRP, that is not a great combination. Now, people have tried to address this hyperferritinemic issue and looked into treatment. We had a wonderful debate about HLH04 protocol and targeted cytokine treatment. And it's becoming very clear now, you don't have to go full gongo with all those drugs. You can have a targeted approach, and that is what this paper is about. And they found out that without going through a complete HLH94 protocol, using much less immunosuppressive therapy, it seems to work okay in these kind of conditions. This is again a good paper which looked into where else hyperferritinemia happens. In the macrophage activation syndrome, in Still's disease, in APLA, and what therapies they use is the steroids, IVIG, plasma exchange. So that is something we can use even in dengue. What I try to do here is we try to draw up our experience looking into our own patients for the last 1 or 2 years. We have not been doing ferritin very frequently before. That is something we started doing more often this year compared to last year. But we have been doing a little bit of ferritin on and off, not in a consistent basis. So we looked into our data last year and a little bit of this year. There were totally 348 patients with severe dengue admitted to our ICU, of which we didn't have a complete data in 67 patients. And finally, we had an inclusion criteria where we looked into those patients who are dengue, who stayed more than 48 hours in the hospital and had at least one organ dysfunction in the form of either kidney or the liver, or needing ventilation, and high CRP. So we took this combination where the CRP also was very high, and we looked into it. And we had total 65 patients, of which we have only data of 44 patients with ferritin. So when we looked into this data, it was quite interesting. So I've divided this into less than 500, 500 to 1,000, 1,000 to 5,000, 5,000 to 10,000, 10,000 to 50,000, 50,000 to a lakh, and more than a lakh. More than a lakh, the number is small, though we had few more patients, we didn't have data to look into it. There are quite a good number of patients, about 10,000. So what is it we can see here? What I want you to have a look here, it's a busy slide. Obviously CRP is high because that was our inclusion criteria. You can see that moment ferritin crosses above 5,000, the ALT/AST significantly parallelly goes up. And also what we can see is the bilirubin also starts going up once it's beyond 5,000. So that was an important, interesting observation. And when we looked into the immunomodulation we have given and outcome, what we can see here is it's very interesting that the outcomes in 10,000 to 50,000 is better than 5,000 to 10,000. So it sounds like only 8% mortality rate was there in a group between 10,000 to 50,000, whereas 50% died between 5,000 and 10,000. I agree they are not great big numbers, but nonetheless, it kind of gives us a trend. It's a very interesting trend. If it is above 50,000, everyone died. 1 lakh, everyone died. So how is this 10,000 to 50,000 survived, whereas 5 to 10,000 did not survive? Answer might be in the immunomodulation, because 92% of them received immunomodulation when they are between 10,000 to 50,000. Because the study showed that 10,000 means always HLH, we started treating above 10,000 as a cutoff for us for our immunomodulation. Almost nobody got immunomodulation therapy when it is 5,000 to 10,000. So it appears like probably 5,000 might be an appropriate cutoff, because if you don't treat them, it sounds like their mortality is very high. And also what we can see here is if it crosses 50,000, no one survives. So what it tells is the time sensitiveness of this intervention. Probably you should start treating them when it's 5,000. Don't wait for a day or two to cross 50,000 and then you try to do immunomodulation and then you do all the circus, add a lot of immunomodulation therapy. It is a damage controlling exercise. We don't want the damage to go to that extent. They don't do well. So when we looked into, we started using Anakinra a bit in this year, and thanks to Dr. Chandrika, that is something which was made available in our unit, and we started using it. And we started reviewing a lot of literature, because before using it to see if that would work in this particular patient group. So this is again a study done in 2011 where they reported only 8 children, critically ill children with severe HLH, and they found that when they used anakinra, the outcomes were quite good. They did not find any increased secondary infection in this particular cohort where they used. Subsequently, this again a study Dr. Joe Carcillo also mentioned where they reanalyzed adult data of anakinra and its use in septic shock. They found out that those who had hepatobiliary dysfunction and a DSC combination, in them the interleukin-1 receptor blockade had a far better outcome. When they did not have this, when they used anakinra, it did not improve outcome, but did not worsen the outcome. The beauty about this drug is its half-life just of around 4 to 6 hours. It doesn't last in the circulation for too long. So this is what we've been trying to use. And again, this experience of immunomodulation is all over the place because we have taken last 2 years data. So I don't think we can read too much into it because we've used it in a very patchy fashion. That is something we started using systematically from this year onwards. And every patient we've been debriefing, we've been looking at our practice and trying to see, go through literature and trying to see what best we can do. So what we have come out here is, what you can see here is, when we looked at last 2 years practice, we've used pulse dose steroids. We have used low dose steroids. We have used high dose pulse dose steroids with IVIG. We have used low dose steroids with IVIG. We have used pulse dose steroid with anakinra. We have used anakinra plus IVIG, and we have used combination of all these 3 drugs. It's a bit difficult to interpret, but at least, when we wanted to look at this data, we are wondering whether we are comparing dissimilar groups, whether someone were really sick and advanced disease, and then you used it very late, and some you used it early, and there are a lot of confounding factors to interpret this data. But I think I would want you to look at this ferritin level. When you look at this pulse steroid group, the ferritin levels, these are mean ferritin levels, were on 20,000, whereas in anakinra and high anakinra group, it's like 60, 40,000. There are very high ferritin levels. And even high dose steroids have been, with IVIG has been used in the mean ferritin levels of around 50,000 plus. What we can see here is that when you use pulse dose steroids alone, almost everybody died despite the ferritin levels not being too high compared to other groups. It was around 20,000. But when we use anakinra in any combination, it seemed like making some amount of difference. Again, I agree that these are very patchy. It's difficult to make strong conclusions out of it, but at least we can say that probably using steroid alone is probably not safe. Why? Especially in a pulse dose format. When used in low dose format, but again, the confounding factor was the ferritin levels were not high. Probably these patients were not sick enough. That's why they survived. But when we look at pulse dose steroids used in any combination, whether it's using IVIG or anakinra, almost everybody died. So it looks like this pulse dose steroid seems to be having a very significant immunosuppressive effect. And that's the reason I was trying to tell that in the first slide, that there is both hyperinflammation as well as immunosuppressant effect, which happens, immunoparalysis, which goes hand in hand in these patients. And ferritin itself tends to have a lot of immunosuppressive effect. And this is looking at our own data about how many of these patients had sepsis. A lot of them actually at the time of admission, the first blood culture did actually show sepsis, significant amount of fraction. And when we looked into our own data here with regards to ferritin and sepsis, sorry, into sepsis, almost everybody, once a ferritin crossed 50,000, everybody had bacterial sepsis. So it seemed like a dose dependently, when the ferritin went up, they always had a bacterial infection. So it could be, like we discussed in my study, that this combination of bacterial sepsis plus virus, it seems to drive ferritin very high. And a lot of, unfortunately, again, I'm not told about other category of patients. There are category of patients whose WBC count is very low, and we have given GM-CSF in them. It stays low for 3 to 4 days, and we have seen and then they become afebrile, and they develop fever again on 7th day, 8th day, and the blood culture comes positive. And their WBC counts are very low for 2 or 3 days. So there's a category of patients, like what they've described in influenza. There is immunoparalysis in certain group of patients where they don't have hyperinflammation. It's purely low WBC count. They catch a new fever, they become septic. And interestingly, when you look at all these patients, even our own patients who have not been to any other hospital, directly coming from the community, these are all multi-drug resistant organisms. Like what we see in UTI nowadays, everyone has a multi-drug resistant organism. And this is a great difficulty for us. Probably that's the reason why the pulse dose steroids doesn't do that great, because what it does is probably pushes you more towards the immunosuppressive phase, where the IL-10 becomes dominant, and then you add steroids. And top of it, you have a lot of this great difficulty in our context, where this patient come with both bacterial sepsis, which are multi-drug resistant, which means we don't know what antibiotic we are using, whether it's sensitive or not. It makes us very hesitant to be very aggressive with this steroid therapy. And this again, because the ferritin levels more they're high, that is time where we use pulse dose steroids. And unfortunately, those are the patients who seem to have bacterial sepsis and who, if you don't treat with an appropriate antibiotic, they die anyway because you can't control hyperinflammation in the face of fulminant sepsis. So there are reports of aspergillus, and there are reports of aspergillus. Our own and a few of my colleagues and friends, when I've spoken to them, they've seen aspergillus in the follow-up of these patients with dengue. And we know even in septic literature that once your immunity gets affected, that dysregulated immune system can stay up to a year. In fact, the mortality rate actually goes up to a year or two. People die much later when they go out of sepsis too. And even in these patients, we've seen patients in our own experience who come back with sepsis. And there are literature where people have seen brain abscess developing the follow-up too. So now this is a study, a very popular study by Anand, who looked into the onset of hypotension and using antibiotics. What he found out is every hour delay in giving antibiotic increased mortality rate by 10%. My question to all of us is, do we have a similar time frame for immunomodulation in dengue? Because the time frame is so small, this disease progresses to significant vascular leakage within a matter of few hours. Children who are stable, many times people have seen children stable come for morning rounds, they find in profound shock. Within a matter of few hours, these patients progress so rapidly. We don't have antibiotics. It looks like it's an immune-mediated mechanism. Instead of antibiotics, should we be considering immunomodulation in this critical phase very early to prevent this rapid progression? So that's a question for us, all of us, for us to think. So what is it we do in our unit? This is again immunomodulation protocol. We kind of developed, kind of refining it over time with the help of Dr. Chandrika, who's been a great help in kind of defining what protocol for us to follow. So what we have come up now is anybody with ferritin more than 5,000 and as demonstrating a progressive illness in the form of end organ dysfunction and need for significant increase in fluid requirement, like you're needing 10 ml per kg every hour for 3 hours, and there's evidence of metabolic acidosis. That means you're actively leaking and there's acidosis, or you have demonstrated that the liver is affected and you have ferritin more than 5,000, we decide to treat them currently. We always start them once it causes more than 5,000 now on antibiotics based on our experience, and we start them with broad spectrum antibiotics, and we start with IVIG and anakinra. So yesterday we debated about Randy-Cron whether IVIG is really essential or not, because the cost issue is significant, especially in children who are older. Anakinra, the beauty of IV chose is purely because its half-life is so short, does not have a prolonged immunosuppressive effect, and all this story what I've told about how patients do come later on with sepsis, with reactivation of viruses, with fungal sepsis, with steroids, and our own poor outcome with pulse dose steroids. That's the reason we've shied away. Till the culture report comes, we don't start them on steroids, we start them on anakinra. And that's a challenge. A lot of people did ask questions in the last couple of days, why don't we use Dexa in dengue? But the problem again in Dexa is a very long-acting steroid. And this immunosuppressive phase, it can probably make it even more worse. That's the difficulty of using that steroids. We start plasmapheresis if it crosses 50,000, or if we decide to give any blood transfusion. So, or if there's a demonstrated liver failure, even if ferritin is not 50,000, it's much lesser than that, we start plasmapheresis, especially if you want to give blood, because this free hemoglobin again drives the ferritin very high. So we don't want free hemoglobin to happen. So we use plasmapheresis in them. We titrate anakinra response to the clinical response and to the lab response. Like I said, steroids, once we are sure what culture we have grown, what a sensitivity pattern, patient has to literally earn steroids. So we kind of, when we think we are pushed to a corner, when you rule out bacterial sepsis, we consider steroids. And during this immunomodulation phase, so many of us get confused whether the immunomodulation itself causes sepsis, but it's, I think, becoming more clearer that it's a host factor which makes them more susceptible. These patients would have died otherwise. They now survive through this phenomena. When they survive through this phenomena, they still have a dysregulated immune response, right? So they still are in this immunoparalysis phase, which makes them the viral reactivation much more common. Fungal infections, bacterial infections more common. So you have to actively look for it. Why? Because it becomes difficult at times, because a lot of these parameters we use like CRP and all that, it kind of are not very clear whether there is infection or not, because these are controlled by these drugs. So a lot of these lab parameters to diagnose infection becomes difficult. So you need to really carefully watch for any evidence of infection. So with this, I would conclude my talk. It appears like the critical phase of dengue seems to be mainly immune mediated. It appears to us from the available evidence that you could actually use steroids in the early critical phase to prevent it from progressing, but we need a large studies on this to understand that role. If it happens, it probably can do a huge amount of benefit. There seems like there's an opportunity for immunomodulation during organ injury phase. In the early phase, it appears to us that if you wait for too long for immunomodulation, allow ferritin to cross above 50,000, it is too late. No kind of immunomodulation seems to be saving them. So this is a whole beauty, because a lot of us do feel that many patients with fluid therapy itself get better. So we need to identify this group of patients who would get better on themselves without any immunomodulation. At the same time, we should not wait for a group of patients where immunomodulation is so late that in the end we say, oh, immunomodulation does not work. So it appears to me that based on, at least on our data, if you start immunomodulation once it crosses 5,000, it seems like it can actually prevent death. Ferritin probably is a CRP for us in viral sepsis. The way we use CRP to treat bacterial infection, we can probably use ferritin. Anakinra and IVIG seems like a reasonable option for us immunomodulation. The concurrent bacteremia seems to be commonly associated in severe hyperferritemia. Always consider antibiotics. Don't think that it's dengue. There's no need for antibiotics. At the same time, when I say that, you should know if there is no hyperferritemia in mild dengue, moderate dengue, we should never use antibiotics. I'm talking about a condition where patient lands up with severe hyperferritemia in ICU. So watch out for bacterial infection, viral reactivation while on immunomodulation therapy, and use steroids very carefully. With this, I would conclude my talk, and I would really thank my ICU team, all our past fellows and current fellows, for all their hard work and helping me to collect this data. And I especially thank Dr. Pavitra for all her hard work in terms of getting this data of last 2 years and helping me with this presentation. So thank you very much. And with that, I would conclude my talk. If there are any questions, I would take them up, please.
Thank you, Rakshay, for that comprehensive evidence-based overview of a possible role of immunomodulation in dengue. So from your presentation, it seems that yes, there is a role, and we probably should start looking and identifying that cohort of patients who are going to benefit from early immunomodulation. Having said that, I would just like to put 2-3 riders after having listened to your talk. One is that time sensitive. The progression of this disease is very time sensitive. The pathophysiology evolution is very time sensitive. So therefore, when we identify this cohort, it's very important for us to remember these time sensitive evolution. So not all patients may be in the similar bracket. And second rider, I feel, is that there is an overlap between the pro-inflammatory and the anti-inflammatory cascade, as you have rightly pointed out. So it's a very thin line or a tight rope that we would be walking when we consider immunomodulation, because we don't want to push the patient on to a immunosuppressed state and further aggravate the chances of secondary bacterial sepsis. And third, I think it's important for all of us to differentiate dengue and a bacterial septic shock. This is very, very important. Though we have seen that both can easily coexist with each other. So as clinicians and intensivists, I think we all need to remember that the role is definitely there. And probably with a few years of more research, I think there would be more light on all this. But till that point, indiscriminate use of steroids or indiscriminate use of any immunomodulatory therapy is something that we have to be very cautious about. We have already seen those things happening with the COVID pandemic. So therefore, selection of the right cohort of patient is probably an important take-home message here when we consider immunomodulation. And I saw one important question, which I think, Rakshay, you should address, even though you have a little bit of time we have overstepped. There was a question in which the participant has asked that there is a patient who comes with liver dysfunction, but the ferritin is not elevated. So should we consider thinking about CRS and immunomodulation in such patient? And as an extension to that question, the WHO definition talks about an expanded dengue syndrome where they come with elevated transaminases. So therefore, just clarify for the audience that what is that where we would consider CRS, hepatic dysfunction with ferritin, raised ferritin, hepatic dysfunction without raised ferritin, because I think this is an important message and clarity that needs to go out.
Yeah, I think, ma'am, I concur with all your views, and I think careful patient selection is important. And I think the great difficulty for us will be defining which patient will actually benefit from this. For that, we need to really look into our data that with current existing therapy, who survives and who don't survive. What are those predictors? And try to see which are those patients we can do. And that's what we try to just look at our data. So what it appears is, at least from the available literature, once a ferritin crosses 5,000 and you have evidence of transaminitis, evidence of liver. Now again, OT again can be just an inflammatory marker. STPT going up, bilirubin going up, then that becomes probably candidate, because now you have ferritin, you have evidence of an end organ dysfunction. That's probably a cytokine related mechanism, because if this ferritin itself goes up, there are studies, like I mentioned, to show that that itself can perpetuate liver injury to fulminant hepatic failure. So that is what we are currently thinking. Now, if ferritin is on the lower end, it's not normal, then I don't know, because it's a bit tricky, because there is this whole phase where there are patients who have predominantly immunoparalysis. And we have seen in earlier studies also that a low ferritin response, like I just mentioned, like less than 200, for example, has been associated with poor outcome. And even in our own cohort, if you see less than 200, almost significant amount of them are actually septic. The blood culture was actually positive. So in them, I don't think immunomodulation becomes a therapy. We have to look for bacterial sepsis and you have to look for antibiotics and treat them like a septic shock, I think. So that's what I can understand and gather. And I think we have a lot of other experts too in our panel. Might be they can also share their views. There's Dr. Ramanan and Dr. Randy Cron. Maybe they can also share about what do they think, because I don't think there's a right answer. I'm just saying from a little bit of my own experience, whatever I could understand from the literature and looking at our own experience. To say that this is a recommendation, do it this way, I don't think it's right for me to say at this moment in time.
Thank you, Rakshay. I think there's a lot of food for thought now. You can look at the questions in the QA box as well as the chat box, and maybe you can answer them for the participants. Thanks once again. I would now hand over the further proceeding of the sessions to Dr. Jagdish Chinnappa to take over and introduce the next speaker. Over to you, Dr. Chinnappa.
Thank you, Dr. Rakshay. Thank you, Dr. Chandrika, for inviting me to chair this very important session with Dr. Jayashree. We are coming to the almost last part of the cytokine release syndrome in children conference, which has been valiantly organized. And Dr. Rakshay has opened a Pandora's box. We still have to do a lot of study to really know which patients will benefit from immunomodulation and how to go about it. So I think we are at right time to now look at targeting cytokines in CRS. What are the future trends? What are the molecules that we will be looking at? What are the tests that we will do to justify use of these molecules? We have a brilliant speaker from Alabama in Birmingham, Professor Randy Cron, whom we heard yesterday during the case discussion on dengue, giving his very valuable comments. He focuses on the study of heterozygous mutations in familial HLH and novel genes which contribute to the CRS cytokine storm syndrome. As you can see from the slide, he has got a very distinguished career, starting from his pediatrics residency at the Stanford Children's Hospital at Palo Alto, University of California, MD, a PhD in immunology, a postdoctoral fellow from Stanford again, a pediatric rheumatology fellowship, a National Institute of Health Bethesda scholar, and a BS in biomedical sciences. So I invite Professor Randy Cron to tell us about the future trends as far as cytokines in CRS.
Thank you very much for the invite. Can you tell me if you're seeing my full slideshow or my...
Yes, it's full slide, sir, and you're audible.
Excellent. All right, thank you. And again, thank you for the invite. This is, like Dr. Khan and others mentioned, this is a really a great forum. I do have some relevant disclosures. And I'd like to talk about some of the pathophysiology of disease before I get into the meat of the treatment, which we've heard a lot about already today, just because I think it does inform what choices of medicines we may employ. But I'll start with the case. And actually, this was the patient that got me very interested in this and shifted my research focus at the time. So I was in Philadelphia at the time, and this was a 14-year-old girl who came to us with a prior diagnosis of cytophagic histiocytic paniculitis, something I'd never heard of and hope to never see again. And she had been diagnosed at a young age. And unfortunately for her, she suffered fevers every single day, high fevers. She had total body paniculitis and lipoatrophy. She really had no fat. And she presented to us with belly pain and a large liver on exam. And even though she was 14, she was really the size of an average 7-year-old. We surmised either from chronic steroid use over the years and or just chronic undertreated inflammation. And seeing the word paniculitis in her diagnosis, we started her on cyclosporin and glucocorticoids, and she got a little bit better, but unfortunately she was back to our hospital within a month, except this time she was admitted with abdominal pain, and she seized and was comatose and got moved to the intensive care unit. She had inflammation in her cerebral spinal fluid and in her blood. She was coagulopathic, pancytopenic, hyperferritinemic, and quickly progressed to multi-organ system failure. So she was on, I think, 3 different inotropes to support her cardiac function. She was an ARDS. She had renal failure, liver failure, pancreatitis. Her cell lines were in the toilet. She was bleeding from multiple orifices. For me, actually, she was one of the sickest kids I've ever seen, who eventually came out of the ICU essentially unscathed. This was her bone marrow at the time, and it showed the classic hemophagocyte. We got this in retrospect. This was at 9 months of age. This is her fat that's infiltrated by all these lymphocytes that do not belong there. And despite the fact that the HLH04 criteria are many times far too restrictive for secondary forms of cytokine storms, she was sick enough to meet these very easily. And I won't belabor them because people have talked about these quite a bit. They initially had called the haemato-oncologist. This is back in 2004, because they had a protocol for treating cytokine storms like HLH. And she was started on etoposide. They increased her cyclosporin dose and put her on dexamethasone as part of the HLH04 protocol. But she was actually clinically worsening, and her labs were getting worse as well. And they realized that we had seen her earlier as an outpatient. And so they called us, Ed Behrens and I, who was my fellow at the time. And this was around the time in 2004 where we had started as rheumatologists using the drug anakinra to treat children with systemic juvenile idiopathic arthritis, because it was really a game changer for those kids. And because many of those children with systemic JA will develop MAS or a cytokine storm, we reasoned this girl was going to die. I was pretty convinced of that. We were all pretty convinced of that, that we could try IL-1 blockade because it might help. And we talked to the family, obviously, we talked to the rest of the team and decided to go forward with it. And within 2 days, she woke from her coma. Within 6 days, she was out of the intensive care unit. She was out of the hospital within a couple of weeks. And it was really nothing short of miraculous just by adding anakinra to her therapy. And so as a kind of a generic understanding of what we think is going on for a lot of cytokine storms is shown here. So on the y-axis, we have the generic strength of the immune response with time marching along the x. And let's say you're a normal host and you get an infection, could be influenza, for example. Your immune system will hopefully mount an appropriate response to that infection, begin to clear the infection, and then your immune system's actually hardwired to shut itself down. Otherwise, we'd be one giant lymph node, like an ALPS patient, for example. But what's thought to occur in many of the cytokine storm syndrome, including HLH, is a defect in the ability of your natural killer cells and your cytotoxic CD8 T cells to kill off these infected antigen presenting cells. And that results in a prolonged engagement. And this was modeled by Michael Jordan, the pediatric haemato-oncologist, not the famous basketball player, when he was in Pippa Merrick's lab in Denver, Colorado. And what Mike did was he took wild type or normal genetic mice and compared them to mice that were homozygous, deficient in perforin. And these perforin deficient mice are perfectly fine in the mouse colony until they get the wrong infection, in this case, the LCMV virus. And the wild type mice, the CD8 T cells will recognize these infected antigen-presenting cells. They'll begin producing pro-inflammatory cytokines, including interferon gamma, and they will kill or lyse these cells and shut down the viral life cycle. And they clear the virus and they do fine. The perforin deficient CD8 T cells, they will also recognize the infected cells and produce interferon gamma, but they can't kill. And these mice uniformly die within 10 to 14 days. And that's a great story. And if he had stopped there, it still would have been a great paper. But what Mike did, and we've seen this data somewhat already in this conference, is he blocked either the CD8 T cells in these perforin deficient mice that were infected, or specifically blocked interferon gamma. And you can see how that prolonged their survival. And this is a really important concept. And I think something that all clinicians need to know, because we're recognizing the breadth of cytokine storms in general. And that is, the virus here was the trigger of this hyperinflammatory immune response, but it was the host immune response that was killing the mouse, and similarly what we think occurs in humans. And so in addition to perforin, there are a variety, and we've seen some of this already in this conference, of these familial forms where you're homozygous deficient in any of these proteins that are important for perforin to do what it does. And that's shown in this cartoon here. So on the left, we have either a natural killer cell or a cytotoxic CD8 T lymphocyte. They share the same pathway. And perforin is pre-existing in these cytolytic granules along with proteins like granzymes. And when this cell recognizes its target cell and becomes activated, these perforin-containing cytolytic granules will traffic along the active cytoskeleton to this immunologic synapse between the cells. And all these funny named proteins, Rad27A, Syntax11, Monk13-4, et cetera, they're critical to this process to occur. And then perforin will get released and form a channel or pore between these cells, allowing for delivery of granzyme, which triggers this apoptotic cell death. And here's another really important paper, and there have been confirmatory papers since then from other groups, that Misty Jenkins and colleagues in Australia performed. And what she did was she took human or mouse, CD8 T cells or NK cells, didn't matter, granzyme deficient or perforin deficient, didn't matter, and observed the interaction by time-lapse imaging. And what she found is if you were defective in this perforin-mediated lytic pathway, that the time spent between the lymphocyte and its target cell was 5 times longer. Okay, great. What does that mean? Well, that results in increased pro-inflammatory cytokines such as gamma interferon or TNF, which are thought to lead to the eventual multi-organ failure that is associated with cytokine storm. So this is kind of direct evidence that this lack of killing contributed to this pro-inflammatory cytokine storm. And we've all seen this multiple times as well, so I'm not going to belabor it. But there are multiple pathways to get here. And I think, as Scott and others have pointed out, this is really important because they're not all the same. They share many common features, but there are multiple ways to get there, including high levels of IL-18 and interleukin-1 in diseases like systemic GAA or NLRC4 mutations. There are these familial forms, which is maybe 1 in 50,000 live births, so not that common, that gamma interferon is obviously very important. There are these iatrogenic causes like BiTE and CAR T-cell therapy for refractory leukemias and lymphomas, in which IL-6 and probably IL-1 is also very important. And then there's a whole slew of different infections we just heard about, dengue being one of them, that there are probably going to be different types of therapies in addition to treating the virus that you're going to go after. So I think it is important to know the pathophys of what's going on before we come up with our chosen therapies. And so this is kind of the outline of what I'd like to talk about, with most of the focus being on the biologic therapies. So early on, even in rheumatology, we realized that glucocorticoids could save lives in these children. And these were many small case series, so not great data, but the kind of the best we had to go by. And then many of these were children with the systemic form of juvenile idiopathic arthritis who were dying from this hemophagocytic syndrome with sick livers and pancytopenia and hyperferritinemia, and steroids could save their lives. Cyclosporin, and I've heard many people say this, and maybe I just am not aware of this. I actually used to study NFAT transcription factors quite a bit, and that's how calcineurin inhibitors like cyclosporin and tacrolimus and voclosporin work, is they keep the NFAT family of transcription factors from translocating to the nucleus to turn on a variety of cytokine genes, including many pro-inflammatory cytokine genes. So I think these drugs work actually very quickly. So I'm not sure why there's been a lot of talk about them not working quickly, but nevertheless, they do also help. And so even in patients that weren't responding to steroids, or if they just gave this drug cyclosporin in this case, that also helped survival in children, primarily again with systemic GIA. We've heard a fair amount about dexamethasone and etoposide in the HLH04 group, and Jan Ingehenter and his colleagues have been instrumental at putting this out there. And that was why that initial patient got treated with that, is because they have these prospective, they're not randomized, but these open label trials to study this, and to their credit, they have. Most of the data is again on secondary forms because the familial forms are much less common. But even back when this was published, 55% survival is not great. It's gotten somewhat better than that. But again, this data is from places that know what they're doing. So in places that don't see a lot of this is still a pretty dismal survival. And I won't belabor the protocol. IVIG, I've said previously in this conference, anecdotally, I haven't found it helpful. I don't find it harmful. If it helps, great. The only thing you might want to do is get some serum set aside before you use it, because that will be complicated by using IVIG. But people have reported case reports and case series that it helps in various infection-triggered cytokine storms. ATG hasn't got a whole lot of attention. Removing all your T cells is a pretty dangerous thing, but if you're dying, as shown in this case series, it can help. There are other ways to go after broad immunosuppression as well. And we've heard a fair amount already about plasma exchange. This was a case series, again, not perfect data, but again, suggesting that removing evil humors, in this case, maybe pro-inflammatory cytokines more than anti-inflammatory cytokines, can benefit patients with cytokine storms. Rituximab, initially was going to be a great drug for Epstein-Barr virus associated, which is one of the most common triggers outside of, I guess, things like dengue of cytokine storms. And early on, it was being used in patients with X-linked lymphoproliferative disease, and actually helps there. But it didn't broadly help others who didn't have X-linked lymphoproliferative disease, who had Epstein-Barr virus-driven cytokine storms. So it hasn't panned out as well. But if you have the ability to tell if it's in other lymphocytes besides your B cells, and it's not, then it seems like a reasonable approach to target the cells that are infected and that may be contributing to the cytokine storm directly themselves. So we heard about, this interaction and this broad expression, in the debate, why is it that targeting individual cytokines makes sense? It doesn't make sense to me, but we also heard about just kind of keeping this balance concept. And to me, your immune system is pretty good about balancing things. And at some point you get over this threshold, if you like the threshold model of disease, where you can no longer balance out the pro-inflammatory situation. And so it is surprising to me, but anecdotally, we know that anakinra works, for example, in that first patient. So it may not even be the central cytokine to the process, but targeting individual cytokines can work to get the balance back in order. So as crazy as it may sound, it is a reasonable approach. And we also heard, TNF inhibitors have been in case reports and case series reported to cause. It's very hard to prove cause and effect. They're giving the TNF inhibitor because someone is really sick, for example. And some have clearly helped. But in general, it may not be the first drug you go to until we get a better idea of what situations where TNF is really one of the major players in the problem. But again, for us, particularly from a rheumatology standpoint, when IL-1 blockade was being used to treat children with systemic GA, which prior to that, we were really dependent on steroids, which is a horrible thing to be on long-term. These kids were miserable. And when Virginia and colleagues in Dallas reported on this cohort of 10 kids who were sickest of the 6 systemic GIA kids that they had, and they just all did great on anakinra, this became just this new wonder drug for these kids. And you've heard me already talk about it, but these are some of the reasons why I really like this drug in general. So again, it's a recombinant human protein. So it's not some toxin or poison. It's something your own body makes. And really you're giving just excess to balance out the IL-1. It's not that you can give endless amounts of insulin, for example, which is another recombinant protein, but here really all you're doing is balancing IL-1. It's very fast acting. So if I use it particularly early on, before things get way out of control, I'd give it 48, sometimes 72 hours before I kind of give up on it or think of even considering increasing it if I'm getting a partial effect. So it's fast acting, that's important. It's got a very short half-life. So even if it was dangerous, and it rarely is, and I've heard a lot of people talking about even, not giving immunosuppression or immunomodulation and worrying about immune paralysis. This drug is not one of those drugs. This is not equivalent to cyclosporin. It's not equivalent to steroids. This is not equivalent, certainly, to etoposide. It just is not that powerfully immunosuppressant, but it's important if IL-1 is a major player in what's going on. It binds both IL-1 alpha and IL-1 beta, and in some diseases that matter and some not. So the antibodies are not going to work that way. They're only going to bind beta, for example. And probably in COVID, IL-1 alpha is important with the endothelial damage that goes on there. And it's got a ginormous therapeutic window. There are very few drugs, if any, outside of a few of these biologics that target individual cytokines that you can 20 times the normal dose and get more benefit without more side effect. I mean, it's just a concept that most people are not familiar with. And it can be given either sub-Q or IV. It's probably better given IV if you can do that. But for example, Ebola, another hemorrhagic fever virus, many people died in 2014 outbreak in parts of Western Africa that were remote because they didn't even have IV access. And if that helped for this disease, I tried to push Tony Fauci to use it, but it didn't get too far. But it may ultimately have a role there as well. And then after our case report, this was a case series that Päivi Matunen put together. Ed and I contributed a couple patients to it. And these were kids who were rheumatologists. These were kids with primarily systemic JA and a few vasculitides who were not responding well to high-dose steroids, intravenous immunoglobulin, cyclosporin, and a few kids that also got started on the etoposide pathway. But again, anakinra fixed this small cohort of kids. And then everyone has talked about this, so I'm not going to belabor it, but even in the setting of severe sepsis, anakinra can help those who have features of a cytokine storm. So it's not a diagnosis of exclusion. I think that's also very important. And people have already reported on this too, so I won't belabor this. Other than to remind people what people have already told us is that the earlier you treat, the better. And so again, with a drug that's not powerfully immunosuppressive, I have no qualms about using this early. And again, really all you're doing is with this drug is balancing out excess interleukin, whether it's IL-1 alpha and or IL-1 beta, and its ability to bind its receptor and signal through that receptor. Other potential cytokines in the IL-1 pathway include the alarmin interleukin 33, which is an IL-1 family member. And I think Ed Behrens is continuing to push this forward, but in a mouse model, he showed that blocking the receptor for interleukin 33 could prolong survival of these mice. Scott and Ed reported on a patient with one of these autoinflammatory NLRC4 activating mutations, in which anakinra helped, but it wasn't enough. In this patient, like in subsets of patients with MAS, had very high IL-18 levels. And so IL-18 binding protein has a very similar role. It's an endogenous protein again, much like anakinra serves for IL-1, IL-18 binding protein helped save this child as well. And so my guess is that various versions of IL-18 blocking agents will become part of our armamentarium as well. We've heard about CART and BITE therapies, iatrogenic causes of cytokine release syndrome in patients who were going to die from cancer. And so these therapies saved them from that. But in about 20 to 30%, they developed this cytokine release syndrome. And IL-6, which is easily measured, I think was one of the reasons they went after it early. IL-6 blockade works very well for the patients in this setting. IL-1 blockade works actually very well too, particularly if you have central nervous system involvement. Emapalumab. So we're coming full circle here. Michael Jordan's mouse model. Now Michael is part of this clinical trial where they're treating primary HLH, the sickest of the sick infants who have homozygous defects in the perforin pathway, right? So this is pretty sick kids who may not need to go down the etoposide pathway. So this is impressive, and this will, I think, continue to get broader use, particularly in many of the secondary forms. Janus kinase inhibitors. So early on, Kim Nichols and colleagues really were championing ruxolitinib. All these JAK inhibitors are not the same, and they're not as specific as they're reported to be, but they have relative specificities. Nevertheless, in this mouse model, perforin deficient mouse model, ruxolitinib helped. And Kim has collected now, over 100 case reports and case series of people claiming that ruxolitinib is pretty good in many different versions of secondary cytokine storms. And so these JAK inhibitors are somewhat intermediate between very broad immunosuppression with glucocorticoids or similar broad immunosuppression of cytokines with calcineurin inhibitors versus individual targeted cytokines like IL-1 or TNF or IL-6 blockade or IL-18, et cetera. These are going to block multiple cytokines based on how the receptors are coordinated for many of these cytokines and how these kinases are somewhat redundant in the various receptors that employ them. So glucocorticoids are great drugs. They have a lot of the side effects, and if you're worried about immune paralysis or you're worried about severe secondary sepsis, you have to take that in mind. But if the patient's dying, they can also save lives. And I actually do like the use of cyclosporin. You do have to worry about things like PRES, reversible encephalopathy. When I've seen that, just anecdotally, those patients have ultimately gotten better both from their PRES and their cytokine storm. Cytotoxic drugs, there's definitely a place for them in the severest of the severe. I don't start with them typically. So particularly for many of the secondary forms. And then we've just gone through, these individual cytokines or a broader immunosuppression of cytokines with the Janus kinase inhibitors. And so we've come a long way. I mean, this is a new field really to medicine, right? So Jan Inge Henter and colleagues paper on etoposide wasn't until the mid 80s. The first gene that was reported, perforin, wasn't until 1999. That case report that I showed you, the first use of anakinra for cytokine storm, that was mid 2000s. We now have FDA approval for tocilizumab as part of cytokine release if you get it from iatrogenic causes. We have emapalumab FDA approved for familial HLH. And COVID-19, this is a PubMed for cytokine release, cytokine storm, MAS or HLH. And actually, truth be told, it'd be way off the top of this map if I had gone for the last 2 years. But it's one of the other kind of benefits in the middle of this pandemic is it has gotten a lot of attention to cytokine storms, both the lay public and clinicians who may or not be that familiar with it. And I'm happy to take your questions.
Thank you, Dr. Randy, for a brilliant expose on the journey of cytokine inhibition. And the explosion of knowledge in the last few years indicates how it's probably going to move into clinical medicine at a much faster pace than we assumed. And I think in this conference, we have looked at some of the common problems we have, like dengue, where this may play a role, and we probably need to investigate a little more in detail. I don't see any questions here. No, there are no questions here. Only comments that it was a very excellent talk. So thank you very much, Dr. Randy, for that wonderful presentation. I hand it back to Dr. Jayashree. Dr. Jayashree, would you want to take over?
I believe, Dr. Chinappa, you have the details of...
Yes, I do.
So you can continue then.
Okay, thank you.
Yeah, right, thank you.
So we come to the last very, very important and very interesting case presentation, which is going to be moderated by Dr. Chandrika Bhatt and Dr. Narendra Bagri. The mentors are Dr. Angelo Ravelli and Dr. Ankur Jindal. Dr. Angelo Ravelli is the scientific director of the Giannina Gaslini Institute of Genoa, Italy, and professor of pediatrics at the University of Genoa, Italy. His field of clinical research activity focuses on pediatric rheumatology. He is currently the president of the Pediatric Rheumatology European Association, PRESS, and the past chair of the EULAR, Standing Committee for Pediatric Rheumatology. He has received numerous grants and awards, including the Gerolamo Gaslini Prize for Excellence in Research in 2004, and a grant from the American College of Rheumatology, ACR, and the European League Against Rheumatism, EULAR, to conduct the project aimed to develop the new classification criteria for macrophage activation syndrome in systemic juvenile idiopathic arthritis. Professor Ravelli was the chairman of the International Consensus Conference, which led to the development of the new classification criteria for macrophage activation syndrome in systemic juvenile idiopathic arthritis, and of the International Task Force that developed the recommendations for the treatment to target strategy in juvenile idiopathic arthritis. Professor Ravelli is author or co-author of more than 400 scientific papers and has been invited as speaker in more than 250 international congresses. On Google Scholar, he has more than 30,000 citations and an H index of 87. So welcome, Professor Angelo Ravelli.
Thank you very much.
The co-moderator for this program is Dr. Ankur Kumar Jindal, who is an MD Pediatrics and a DM Fellowship at the Pediatric Clinical Immunology and Rheumatology at the very prestigious Postgraduate Institute of Medical Education and Research, Chandigarh. He is head of the Angioedema Center of Reference and Excellence. He's the APSID Junior Members Working Party Country Representative from India 2020. He's a founder member and General Secretary of the Hereditary Angioedema Society. He's a founder member and Joint Secretary of the Indian Society of Kawasaki Disease. His primary areas of interest are hereditary angioedema, primary antibody deficiency, Kawasaki disease, scleroderma, and uveitis. Welcome, Dr. Ankur Jindal, to moderate this case presentation. So I hand it over to Dr. Chandrika to take over the case presentation.
Thank you, sir. So Dr. Narendra, if you could just ask your fellow to upload their presentation.
Yeah, good evening all, and thank you for this opportunity. And without wasting much time, I would just, we are going to present two interesting cases which has difficulty in management. So first I would invite Dr. Ashwani, who's a senior resident with us. Dr. Ashwani, please. Yeah.
So, thank you for the introduction, sir. Is my slide visible?
Yes, it's visible. Yeah. Please go.
Okay, thank you. So I would start with the case presentation. It was a difficult to manage case. It was an 8-year-old boy who presented with a complaint of generalized swelling of the body, intermittent fever, and rash on the face for 1 month. He also had myalgia and proximal muscle weakness for 3 days. And there was a complaint of reduced urine output as well for 2 days. There was no complaint of any cough, cold, or other respiratory issues. There was no palpitation, no joint pain, alopecia, or oral ulcers, or photophobia, or any weight loss. There was no complaint of any jaundice, loose stools, or vomiting. So when he came to us, he brought a few investigations from outside. The blood counts were normal, and on biochemistry, there was elevation of AST and ALT. The AST was 1455 and ALT 692. On urine examination, there was proteinuria and few RBCs in hyperfit. So with the complaint of generalized edema and proteinuria, he was referred as a possible case of nephrotic syndrome. However, on examination, apart from the generalized edema, we could also notice some signs suggestive of juvenile dermatomyositis, like heliotrope rash, periorbital puffiness, malar rash, Gorton papules on the hands, and proximal muscle weakness. And his vitals were normal. And in abdominal examination, there was diffuse tenderness. However, there was no organomegaly or shifting dullness, and bowel sounds were heard normally. And other systemic examination were also normal. So with the clinical features suggestive of juvenile dermatomyositis and an investigation with proteinuria, we kept a possible diagnosis of juvenile dermatomyositis with the overlap disease, probably SLE. And we evaluated the patient further. And in the blood counts, we could notice that the hematocrit level was elevated with a PCV of 44.5 to 45.6. And the WBC counts were also significantly elevated. It was 23,880 and 49,370 on day 3, which was neutrophilic. And in the biochemistry, there was hyponatremia, hypoalbuminemia. And as part of evaluation for dermatomyositis, we did the muscle enzymes, which were significantly elevated. And an MRI thigh was also planned. However, as the child got sick, we could not get it done. We did a urine routine microscopy examination, which this time, however, did not show any proteinuria or RBCs. And we did a myoglobin as well, which was negative. And in the inflammatory markers were slightly elevated. The ferritin was in the range of 1044, at triglyceride 742, and PCT 3.7. As we had kept the possibility of SLE as well, we did the ANA C3, C4, which were normal. And the bedside echo was done, which showed a collapsed IVC and with normal ventricular function. And an ultrasound abdomen was also done, which showed loaded bowel with minimal free fluid and gallbladder wall edema. And they also noticed echogenic iliopsoas muscle, probably suggestive of myositis. So with these, we revised our possibilities and we kept a diagnosis of juvenile dermatomyositis in view of characteristic skin lesions, proximal muscle weakness, and elevated muscle enzymes. Possibility of macrophage activation syndrome was also kept in view of increased ferritin and triglyceride. However, the child was afebrile since admission and there was no cytopenias, organomegaly, and other lab parameters were also normal when we evaluated further. And we kept a possibility of infection also. It was high on cards because there was increased TLC, WBC counts and procalcitonin as well. However, again, the child was afebrile and we had done blood culture and urine cultures, which were sterile. And also, since the child had edema and hemo concentration as well, we had evaluated for dengue as well, which was also negative. So, but the things troubling as well, an elevated TLC count along with evidence of hemo concentration, anasarca. So, which were not fitting into any of these parameters.
So, Dr. Ashwini, if you can just pause for a moment.
Dr. Ashwini, thank you for this presentation. As we rightly had seen that this child first deceived us as presentation as a nephrotic syndrome, and most of my colleagues who are practicing rheumatology would agree that at times there could be severe edema, particularly subcutaneous edema in JDM, which may manifest as clinically look like nephrotic syndrome, but actually they are not. And as in this very case, when we repeated the urine RM, it did not reveal any proteinuria. But what was troubling us was this high PCV and high counts and in setting for fluid overload. So I would like to have comments from the house to guide us about the possibilities of this inset, although we could reach a diagnosis of JDM, but what exactly was happening in setting of a GDM, though mass was also kept as a possibility as rightly shared by Ashwini, that the child was afebrile and the other parameters were not meeting. But the troubling points were again the very high PCV and the high leukocyte count.
Can I make comment? Tell me if when I should make a comment on that.
Yeah,
if you wish.
Sure, sir.
Should I make a comment now?
Yeah.
Yes, please do, Dr. Avali.
Let me first say that there are no doubts that this patient had juvenile dermatomyositis because the rash is quite typical. She had at least some of the most typical features of JDM: heliotrope rash, and Gottron sign, but also malar rash is quite common in JDM. At least we see quite frequently, even though it is slightly different from the malar rash that is seen in lupus, because it's less well demarcated. It might involve the nasolabial folds. I don't remember. So this is the difference between the two. One involves the nasolabial folds and the other one not. So this is important. And also in JDM, the malar rash is clearly associated with the heliotrope rash. So it's what is frequently overlooked is that edema in JDM is more common than usually thought. It is usually limited to the face and to the orbital areas, but is considered a sign of severity, of aggressiveness of the disease. It can be also a poor prognostic sign. So the presence of edema might need to require a more aggressive therapeutic intervention to control the disease. And the patient also had a prominent muscle weakness. Of course, it can occur that with the presence of this edema, the disease can be misdiagnosed as nephrotic syndrome because of hypoalbuminemia, which is related to fluid retention overload. But on urine analysis, there was only trace of protein. So, of course, nephrotic syndrome is easily ruled out. So, and also another issue, other lab tests that are not consistent with lupus is the negativity of ANA. So there is no lupus that is ANA negative virtually, and also C3 and C4 were normal. Also, there was no myoglobin, which could have ruled out other form of muscle. So, you know, it is quite known that a fraction, a sizable proportion of children with JDM may have an acute onset, very acute onset with acute inflammation. Of course, there are many who have chronic or subtle or subclinical presentation, but it can be that JDM develops with a very acute onset. In this case was really exceptional in its severity because there was a really remarkable leukocytosis. There was probably capillary leak syndrome with diffuse edema, but still, I think all this, and also there were some evidence of triggering of mass, because ferritin was 1,000, and also triglyceride count was extremely high. There was no fever, I understand, but you should consider that MAS may be slightly different across diverse rheumatic diseases. So we have seen MAS in some cases of JDM. It is often not considered as it occurs with Kawasaki sometimes because people do not think or do not believe that MAS may also complicate these conditions, and therefore corticosteroids are started immediately, which might control the disease and MAS together. So MAS is not diagnosed. But still, we have seen some children with JDM who had, like your patient, evidence of occurrence of coincidence occurrence of MAS. So in my view, what you should do in this case, as you did, is to, on one side, to treat aggressively JDM, because it is clear that if you control the underlying inflammatory process, you might also control the capillary leak syndrome. And on the other side, of course, you should treat this condition with appropriate therapeutic interventions.
Yeah, thank you for your valuable comments, sir. And I do agree with the fact that, yeah, sorry.
Yeah, please, Dr. Narendra, please go ahead.
Yeah, I was just emphasizing the fact that what Dr. Angelo surfaced, that at times the GDM may be tricky, and particularly the edema part is often overlooked, and it may be deceptive at times to make the clear diagnosis of GDM. So having made the diagnosis of GDM, the challenge again, as Dr. Angelo has highlighted was the kind of presentation, the extreme presentation of weakness, as well as the leukocytosis and the raised PCV, which probably was suggesting of a capillary leak which was happening around, which was suggesting that probably the child, and subsequently, as Ashwini will shortly share the subsequent course, can we proceed further so that we learn how the patient moved further, and then probably we can take the discussion. Is it fine? You want to make some comment, Dr. Ankur, now?
Okay, I agree with Dr. Ravelli on all the points. I just thought I'll make some additional comments in addition to what Dr. Ravelli mentioned. So nephrotic syndrome like presentation I think as rheumatologists, all of us must have encountered. And I'm just wondering if this patient was given steroids before this patient was referred to us, because most of the patients that we have seen who presented as nephrotic syndrome were actually treated as nephrotic syndrome, and all of them received steroids. So I'm just wondering, because that can explain 2-3 points in this child. This patient had a little bit of hypertension. At the age of 8, she has a systolic blood pressure of 124.
Yeah.
So a little bit on the higher side. So that probably can be explained by use of steroids. The leukocytosis this patient is having, so that is something which can be explained by uses of steroids. And she's not mounting any fever spikes. So again, so we need to look if she has received steroids. So this is more of an acute presentation, which you sometimes see in patients with JDM. And the edema is a common presentation presenting as nephrotic syndrome. So it's a form of vasculopathy going on in these patients. So that kind of leads to edema. So these patients sometimes present with GI vasculopathy, which is again an acute presentation. Mass may still be a possibility in this child, but considering the fact that she's having high TLC, procalcitonin being high, I would consider infection as a possibility. Even you don't have an evidence of infection in this child, the cultures are sterile, I would still consider covering for infections in this particular condition, in addition to use of immunosuppression for JDM. So I think that is what my take is on this particular case.
Fine. I think perfectly, and they're very relevant point that you have brought. And this is what exactly was happening when we are managing the case. Ashwini, can you just please proceed further?
Yes, sir.
And unfold what exactly happened? Yeah.
Should I second the slide? It's not moving.
It's visible.
Just click on the slide once and then move it.
Okay.
It doesn't proceed.
Yeah.
Okay. Yeah, right. It's gone.
Yeah.
So after admission, this is the further course of the patient. By day 2, the patient gradually started developing features of shock, and he also developed oliguric AKI, and there was worsening of edema and hemoconcentration as well. So keeping a possibility of infection also, we started the patient on antibiotic, piptas and teicoplanin, and infective workups were done. And fluid management was done for the patient, which was a little tricky because as patient was in a fluid depleted state with a collapsed IVC and hemoconcentration and a generalized NSRK and capillary leak as well at the same time. So we had to start the patient on inotropes as well. And on further evaluation, as we can see, the hematocrit kept on increasing, and the WBC counts also increased up to 56,000, which was also butyrophilic. And there was hypoalbuminemia, hyponatremia. For 115 sodium, we had to give 3% saline also for some time. And the repeat ferritin also increased to 6,000, and the other inflammatory markers also increased. So,
if we can just pause here, Dr. Ashwini, and I have a question for Dr. Ravelli here. So would you consider doing a bone marrow at this point in time?
This is an interesting question. It's difficult to say. It's not really fundamental in my view, because the only reason could be the extremely high white blood cell count. But unless you suspect that an infectious complication such as leishmania, I don't think it could be fundamental. But my question, just a question: was the patient already on steroids at this time?
Yeah, so the patient was not on any steroids. Am I right, Ashwani? I think he has not received any steroids from outside when he came to us.
Okay,
No,
so
sir, we did not receive any.
you know, we know that in adults JDM can occur, not JDM, sorry, dermatomyositis may occur as a paraneoplastic syndrome, but in children is extremely rare, exceedingly rare. So with such a typical cutaneous skin picture, with such typical skin manifestation, with profound muscle weakness, with such elevated level of muscle enzymes, I won't really consider a leukemia. So if you would like to be extremely prudent, perhaps a bone marrow you can do, but I won't perform the bone marrow aspirate to confirm MAS, because you know, you have ferritin 6000, so and other triglycerides were extremely high, but it's quite unexpected. They decreased to 231. So in general, what I can say, there are 3 points that I want to make. First of all, there are some complications of MAS or cytokine storm syndrome, whichever way you want to call them, that are overlooked. One is certainly microangiopathic anemia. Which is not the case because hemoglobin it was very good and platelet count was also in some way satisfactory. And the second is capillary leak syndrome, which is another complication where there is a very high level of inflammation. It might occur because of cytokine derangement that is related to this condition. And so, and the third point that I wanted to make is that I had experience not directly, because I was consulted for that patient, that in a child with MAS, it was an isolated MAS with severe capillary leak syndrome, the administration of intravenous methylprednisolone at high dose had a kind of paradoxical effect. It worsened the capillary leak syndrome. Can't explain why, but just would like to give you this kind of anecdotal experience. So it's interesting. So it's at this point, of course, you have the priority is you should work on with therapy on two directions. First, to let's say to control the fluid unbalance, and then on the other hand to try to suppress the underlying disease, because of course this is fundamental to control the underlying disease at the same time as control the fluid balance.
Thank you. I think Dr. Ashwini, you can just carry on with the further course.
With this presentation, with the severe capillary leak, we kept a possibility of JDM with capillary leak syndrome, which was however, rarely seen in cases of juvenile dermatomyositis. And we searched the literature, and we could find a case series published in Rheumatology Journal. And like our patient, these patients also had anasarca. They presented with typical features of juvenile dermatomyositis, and on evaluation, they were found to have elevated WBC counts, as we can see here, even up to 46,000, 22,000, 29,000. And they also had high hematocrit values, and there was hyponatremia and hypoalbuminemia as well. So many of these cases had worsening anasarca, and one of them even required fasciotomy to relieve the compartment syndrome secondary to it. And these cases were treated with IVIG, and all these cases eventually improved.
Thank you, Ashwani, for just once we landed up with the diagnosis of JDM with capillary leak syndrome, this child, the further question was how to manage this child, and this was very tricky because, as Dr. Revelli has just pointed out, that we were dealing with complications like there was fluid leak at one point. There was, at the same time, the child was anuric. At the other hand, the child was in shock. So intensive monitoring the fluid intake output and maintaining the fluid balance was a real challenge. And the second point that what Dr. Ankur has pointed out, that infection was again in our mind, particularly because the child ended up during this season of dengue, and we thought that are we dealing with a coexistent dengue, though it came out to be negative. So fluid management was a big challenge in this child. And then what immunosuppression, because again, because of that paradoxical reaction of methylprednisolone worsening this was again an apprehension. And in this case, though we started with maybe Ashwini, you can take on to the next slide and we can discuss what exactly was done. And then we can take the comments from the experts.
Yeah, right. So now, after admission, we started as mentioned, started the patient with antibiotics and IV fluids, and later inotropes had to be added. And so in view of possibility of capillary leak syndrome, we treated the patient with IVIG 2 gram per kg given over 2 days. And after that, there was a slight improvement in clinical status. The shock features of shock gradually improved. And the patient had a worsening NSRK initially. After around 4-5 days, that also started resolving slightly. And once we have ruled out a possibility of infections, we started the patient on methylprednisolone pulse therapy as well, given for over 3 days. And for AKI, which was believed to be pre-renal, the patient had to be started on hemodialysis. And following that, as we can see, there was a slight improvement in the clinical status. However, after around a week, the condition of the patient again started deteriorating. And there was probably evidence of sepsis, because even though the cultures were negative, we could find a consolidation on chest X-ray, and there was new onset fever as well. The patient started developing features of shock, again AKI, and even though the NSRK has reduced and the hemo concentration was coming down, then again there was pleural effusion. So we had to upgrade the antibiotics, which we upgraded to meropenem and teicoplanin and later colistin. And inotropes were started again, and the patient also started developing thrombocytopenia here, and keeping a possibility of fungal sepsis as well. Since we had given pulse steroid also, we started antifungals as well. So, however, the condition did not improve much, and the inflammatory markers also kept on increasing. So since there was evidence of sepsis as well, we we started the patient on plasma exchanges. We gave around 3 cycles of plasma exchange, and we had to restart hemodialysis also. But unfortunately, the condition kept on worsening. Now, later the patient developed pulmonary edema and a picture of ARDS as well. And we had to start the patient on mechanical ventilation and blood products for the thrombocytopenia and anemia. And the patient went on to develop DIC. And unfortunately, eventually the patient succumbed to illness, and in spite of all these measures.
Yeah, so it was very unfortunate that they will lost the patient. So in this regard, as we were discussing, that we offered the patient IVIG, methylprednisolone, and given the fact that he has an concomitant infection during the hospital course, we resorted to plasma exchange as an rescue therapy in absence of other therapy. So I would like to take comments of Professor Revelli. What else could have been done?
Just a question. What is AKE? Just.
Oh, sorry. It's acute kidney injury. It's
okay.
Sorry.
Sorry. Yeah. Sorry. What can I say? It's as I said in my before, edema is a poor prognostic sign, and capillary leak syndrome is much poorer prognostic sign. So patients with this complication are at high risk of a fatal outcome. If I understood well, this patient died.
Yeah.
Okay, I'm sorry for that. Anyway, what can I say? As Randy, my very good friend Randy, wrote, that child that I mentioned who had anasarca and capillary leak syndrome and paradoxical response to steroid went well with a combination of cyclosporine A and anakinra. but I know that Anakira is not available in India. If I think it is still the case. So what could have been done in this patient to prevent this? Of course, everything is hypothetical, of course, because the patient was extremely severe. He or she, it was a lady, ended up with a microangiopathic complication with DIC and the ARDS. So in general, these patients need to be treated extremely aggressive, not only with corticosteroid, but also with immunosuppressants. And for JDM, the most effective, potentially effective immunosuppressants are cyclophosphamide or nowadays, or rituximab. We have in our unit a very good experience with rituximab in children who are resistant to conventional therapies. Of course, in such desperate case, you need to try desperate therapy. And even I know that there was a high risk of infection, but still there was leukocytosis, so there was no major perhaps risk. Of course, the capillary leak syndrome involves a high risk of infection itself, but in such desperate case you need to be extremely aggressive because otherwise you run the risk of not controlling the underlying process. So you can even associate plasma exchange, rituximab, of course, by synchronizing the administrations, and even cyclophosphamide together. Because this case, I've taken a look of these reports in the literature before the entering the Zoom, but your case is much more severe than those reports in the literature. I mean, clinically, much more severe. So it's
yeah, we do agree that, and it was a severe case, and aggressive management is the key. But probably, though we started steroid, but we could not get a window of starting cyclophosphamide and rituximab because at the same time he got hospital-acquired infection. And
I
yeah,
understand.
so,
I understand. You should balance the risk for infection with the risk of a grim course of the disease, which is, I understand. This is a typical case in which it's very difficult to balance the intervention and the decisions, the therapeutic decisions.
Thank you for your comments. Ashwini, can you just move on to the next slide? Yeah, so before we Ashwini, can you just take it further?
So I just have one comment to make and actually a question to moderators, mentors. So with uncontrolled inflammation and this degree of capillary leak that this child had, these were probably risk factors for developing infection in itself. So achieving a balance with controlling the underlying inflammation with aggressive immunomodulation in the background of, them already developing an infection because of the disease itself. So would you be aggressive at the outset, or would we wait to make sure there is no infection and then proceed? Dr. Ankur or Dr. Raveli?
Ankur, you want to start?
Okay, so I think this was a very challenging case. I agree, and in rheumatology we often see such cases like JDM or SLE, wherein when they present to us, we don't know whether it's more of a disease activity or more of an infection. So a very common situation, but you end up treating for both, and this has been the situation here as well. So in my opinion, the way I would have treated, in addition to what has already been done, and I think it has been managed very well. So I would have probably given a slightly more longer course of methylprednisolone to this child, although I'm not saying that this would have changed the course of the final outcome, but probably give more courses of methylprednisolone, considering the fact that we do not have better immune modulatory therapies like anakinra with us. So that is something which we have been doing and have felt that the outcome kind of improves with the slightly longer course of methylprednisolone. IVIG definitely we would have given. Hemodialysis for renal failure. Cyclophosphamide, yes, we would have given. Although cyclophosphamide, rituximab, they do take their time to produce its effect, but that is something we would have done after giving an adequate cover for antibiotics and antifungals. So that's my take on this case. But I agree, it's a very severe, very challenging case. Despite giving all these therapies, some of these children do not survive.
What can I say? In general, it's I agree with Ankul, but in general, this is a kind of general rule in rheumatology, which this aggressive systemic disease, you need to be aggressive since the beginning. Otherwise, you run the risk of not being able to control the process over the long run. You administer IVIG initially, which is good. It can have an immunomodulatory effect. They are known to work in JDM, also on the underlying disease process. Together with the 3 pulses of methylpres, I guess you have continued with methylpres over time on more conventional dose. The question is, it's as I said, the onset of such a severe aggressive onset of JDM with severe edema, with capillary leak syndrome deserves a very aggressive therapy. So you need to be brave enough. What can I say? To face. I know that in your country the risk of infection is probably higher than in my country, but still, I'm not saying that you were not brave, because I know that it's difficult. It's just for the discussion, just to. But the general rule is severe lupus, severe JDM, severe vasculitis, severe systemic JDA with poor prognostic signs. You need to be aggressive since the beginning with corticosteroid and immunosuppression. Anakinra could have helped, as Randy wrote, but I know that you don't have anakinra, so it's so cyclosporin A is also a medication that could have helped. That's it.
Thank you so much. I think we can move on to the next case presentation then.
Yeah, I think we have discussed this part. I just at the last, I would just want to ask Professor Angelo, do you have your own experience of capillary leak syndrome in JDM, and how do these kids?
I should admit that I have never seen capillary leak syndrome in JDM. I've seen in MAS, in some infectious diseases, but outside, of course, this condition, kind of idiopathic forms, but it's very rare, fortunately it's very rare. No, I've never seen JDM. I've seen cases of edema, prominent edema, particularly of the face, of the periorbital area. In general, I should say that these patients are those who proved more difficult to control. So I can confirm that edema can be a poor prognostic sign, but such a severe capillary leak syndrome I've never seen. I've seen erythromelalgia, diffuse erythromelalgia in JDM, very severe, but capillary leak never seen.
Fine. Thank you, sir.
MAS, I've seen activation of MAS.
Yeah.
Ferritin, leukopenia.
So thank you, Dr. Ashwani, for presenting this case briefly. It was a really challenging case. May I request Dr. Navodit to present the next case? Dr. Navodit is a junior resident with us. Dr. Navodit, you can share your case.
I think in the interest of time, we'll probably restrict the discussion of the next case to key few points if possible, because we've already overshot the time limit.
Yes. I know it's late.
Yeah, so we will just take the discussion at the end only.
It's not our fault anyway, but it's good because there has been a lot of discussion before, which is very good for us. It was a very interesting, important meeting.
Fine. So probably the storm has to settle down now. So
let's try to be short anyway.
Yeah. So we will take the questions at the end only. So over to you, Navodit, please. Navodit. Yeah.
Good evening, everyone. Is my screen visible and am I audible?
Yes, perfectly. Fine.
The second case, there was a 7-year-old boy, RK, with systemic juvenile idiopathic arthritis first diagnosed in March 2018, who presented with a duration of 7 days with complaints of fever, joint pains, chest pain, and a rash on the face and trunk. On examination, the child was afebrile with tachypnea. There was an arthritis of the knee joint. There was an evanescent rash noted on the face and trunk during the febrile episodes. And on cardiovascular examination, there was a pericardial rupture which was auscultated. The possibilities that we kept were a disease flare versus macrophage activation syndrome versus infection, probably of a respiratory focus. The initial investigations, the leukocyte count was 10,600 with predominant neutrophils, and the hemoglobin and platelet count were normal. On echocardiography, there was a minimal pericardial effusion, but normal cardiac function. On chest imaging, there was a consolidation in the left lower lobe on both the chest radiograph and the CT chest. This is the brief pictorial timeline that initially there was fever and arthralgia with need for with tachypnea and need for oxygen support by face mask, which gradually resolved over the course of a couple of days as we started him on antibiotics and stress dose steroids. On initial investigation, the ferritin was 3258 with a cell count of 10,600 total leukocyte count, as we already mentioned. There was clinical resolution of the complaints, but the laboratory parameters showed a rising ferritin, and both the rising ferritin as well as the rising total leukocyte count. So here we had, as we had kept these three possibilities, we had already taken, given cover for the infection with antibiotics. But in view of the persistently increased ferritin, despite giving this initial therapy, we had given a course of IVIG 2 gram per kg for evolving macrophage activation syndrome, because even though the absolute values of the criteria were not met, but the rising ferritin showed a trend in that direction itself. On the in the 18th or 19th day of hospitalization, on the 18th night and 19th morning, the child developed a bout of vomiting, wherein there an episode of vomiting, wherein there were 5 to 6 episodes of massive vomiting, and he went into shock, which required both fluid boluses and inotropic support. And here there was on the investigation, there was established macrophage activation syndrome, and for that, since there was established that they had already given a pulse methylprednisolone followed by oral steroids over a course of 5 days, and even despite that, he developed macrophage activation syndrome, and the ferritin was now on a dangerously steep trend of more than 100,000 or 1 lakh. So we, due to the non-availability of anakinra, we started IV tocilizumab 12 mg per kg and also oral cyclosporin. Now at this time, the cell counts had taken a dip from 29,000 in the second week to now 2,400 with thrombocytopenia associated. And here also, after the tocilizumab cyclosporin, the very next day, the fever and arthralgia resolved, and inotrope support was tapered. The tachypnea and oxygen support, he also required high flow nasal oxygen for a couple of days, and after that it also was tapered, and the child clinically there was resolution, as well as there was laboratory resolution with dropping ferritin and improving cell counts.
Yeah, just 1 minute, Dr. Navodit, if you could go back. I would like to ask Dr. Ravelli here. So at the point where this child's counts went up, so the ferritin also went up simultaneously to 18,000, total counts were 29,000, platelet count was 8.7 lakh. So we know we have now different criteria laid down by your group, and then we had the MS criteria to distinguish between a flare of systemic onset JIA and the onset of macrophage activation syndrome. So going by that, what would your thoughts be at this point in time, whether, although probably the management wouldn't drastically change, what would your thoughts be regarding the diagnosis of?
This is, I understand that the differential diagnosis might consider these three possibilities, but also you should consider that look at ferritin. Ferritin level which raises from already 3,000, which is quite uncommon in the acute setting of systemic JA without MAS. It raises to almost 7,000, then 18,000. In such case, irrespective of the other laboratory tests, I would treat this patient as an impending MAS, at least, an impending MAS. And because we know that if you don't control MAS early enough, MAS may reach its full-blown stage. And then this is what occurred, because after a few days, the ferritin raises to more than 100,000, and the platelet count dropped to 40,000. So this was a clear-cut, unequivocal MAS. Then you had to give the pulses of methylprednisolone. So in general, this is a general rule. In severe cases, it might be, let's say, wise to after the pulses to continue for a while with conventional dose steroid, but still maintaining the intravenous route, because sometimes, particularly in JDM, for instance, but in other diseases, can be kind of inflammation and vasculitis may induce kind of malabsorption, gut malabsorption of medication. So it might be, I say, in severe instances, prudent to continue for 5-7 days, 3 days, 5-7 days. Conventional dose 2 milligram per kilo, 60 milligram, 80 milligram, whichever dose you prescribe, but given intravenously. And then a question, I guess, might, so you were correct in adding cyclosporin A because of the severity of the case. You know, this is with such high level of ferritin, you need to be, and this drop, profound drop in cell counts, you need to be aggressive as you were. But I think I agree with your choice of tocilizumab because you know, Professor Kron would have certainly said use anakinra, but once more, if you don't have anakinra in your hands, you need to be brave enough, because once more, desperate case, very high risk case, need physician to be brave, but also rational, you know. So the tocilizumab we have seen from the presentation of Randy as a role, definitely has a role in the pathophysiology of MAS. The experience with tocilizumab is very limited. Someone might be worried because there are reports of MAS occurring during tocilizumab therapy, but there are also reports of MAS occurring during anakinra therapy, particularly at lower doses, but also with canakinumab therapy. So it is unclear in this case whether it is the medication or intercurrent infection or an insufficient control of the underlying disease, the causes of MAS. But I think there are reports in the literature, either in systemic, both in systemic JA and in adult onset disease, that tocilizumab may help to control MAS. So if you are in a difficulty with the patient, I think I think it was correct to try tocilizumab, which indeed helped very much to solve the situation.
Thank you, sir, for your comments. And in fact, this was the confusing scenario that because we had already given the patient IVIG and IV methylprednisolone for 5 days, and after that the ferritin just steeped to more than 1 lakh, as we have heard in the previous discussions, that such frightening values and accompanied with the clinical deterioration in form of shock, we were left and we chose to give tocilizumab, and then probably the things improved. Yeah,
you might consider reporting this case, publishing this case, because there are only few. I have taken a look at the PubMed before the conference, and there were very few cases, but there are still some positive experience with tocilizumab in MAS. So your contribution may be an interesting addition to the literature.
Sure, so we will take this. Yeah, Navodit, you can proceed further.
Thank you, sir. So as this was a trend of the parameters over the course of the weeks, wherein the absolute values met the 2016 mass criteria only when the frank clinical manifestation accompanied with shock developed. But otherwise, the only ferritin count was meeting the criteria, and the other parameters were, even though inflammatory markers were increased, but the other parameters were not meeting the absolute criteria. So herein, I think there was that the trend showed an evolving mass, as both Dr. Narendra Bagdi and Dr. Anjal Velli previously mentioned, that it was an evolving kind of stage. So the absolute criteria may not be met early in the course. On follow-up, he was prescribed oral cyclosporin with prednisolone with biweekly IV tocilizumab. He improved clinically and both laboratory resolution after the tocilizumab. As I think in the previous presentation by Dr. Rakshit Shetty, the children with more than 100,000 ferritin, none of them survived. But thankfully, in this case, I think probably due to the tocilizumab and oral cyclosporin that we started, the child thankfully improved, and he was discharged at day 29 of hospitalization. And at 4 weeks of follow-up, he was doing well. As was already mentioned, that there were conflicting case reports in the literature regarding the use of tocilizumab, wherein in some cases it elicited the macrophage activation syndrome. The exact mechanism that was postulated is not clear, but it is said that there could be selective inhibition of some cytokine pathways, which could enhance the signaling in the other transduction mechanisms. And so the concomitant therapy that which is around the time of starting tocilizumab could also have an effect in this. There have been some positive successful case reports also with this Russian study, the Japanese study, and the Chinese case series of 18 patients, so showing a successful tocilizumab therapy for the macrophage activation syndrome. So the key point of discussion as is discussed, I think already, that could tocilizumab be considered as a therapeutic option for macrophage activation syndrome? I would like again to open this to the honorable experts.
I would add a short sentence, comma, when anakinra is not available. You might add it in brackets, perhaps. Actually, because not unexpectedly, most reports come from countries where anakinra IL-1 inhibitors are not available. So clinicians need to do something,
Yeah,
I would like to mention one point, that it was we had written it in the after mass, that especially in settings where anakinra is not available, but I was just for the pictorial depiction purpose, I removed it just a few minutes back.
Fine. Okay, thank you, Navodit, for an excellent presentation. So I think this was again a case which has summarized one of the key messages of the conference that we have been discussing, that is the trend of parameters in the clinical parameters trend which defines the mass, not the absolute values. So thank you for this. And any further comments, Dr.
If I can add the last point,
yeah,
consider that criteria for MAS and also for they are classification criteria, not diagnostic criteria. So the diagnosis should be made by the clinician based on his or her skill and experience. Of course, it can be a good reference, the criteria, but do not stick too much to classification criteria, because we know that clinical work is maybe the clinical scenarios may be different. They may require not all syndromes present as it is written in the books and in the publications.
So thank you so much, Dr. Ravelli, Dr. Ankur, Dr. Narendra, and team. I think with this, we'll end the case discussion for today. And I would like to call upon Dr. Rakshay Shetty to now just end the session for the day. Thank you.
So we've come to the fag end of third day of cytokine release syndrome conference. It's the first time we did a unique meeting with a mixture of both rheumatologists and intensivists, and looking at the participation, I can say that it was a very successful meeting. And the success can be measured not only in terms of the number of participants, but how the engaging participants were, and also what are the learnings for each of us. And I'm sure this meeting met its objectives. The objective was to explore the world of cytokines in terms of improving outcomes of critically ill. And I'm sure it was eye-opener for many of the intensivists and many of us who are working in this particular country. I think a lot of those talks were highly useful. And I'm sure also for rheumatologists too, I think the perspective of intensivists, I'm sure, was useful. I would really thank all the experts who joined us across the globe for spending your valuable time. And many of you have been here for all 3 days, especially Dr. Randy Crown, Dr. Scott Scanner, Dr. Pooja Mehta, Dr. Ramanan. I mean, it means a lot to us. I mean, you being here and spending time with us, understanding our concerns, and being very active in the group and answering a lot of our queries, that means a huge. And we all deeply appreciate the kind of effort you put to spend time with us. At the same time, all the delegates who joined over the last 3 days in good numbers across the country. And not just that, I mean, the chat box has been busting with so much of comments, content, discussions, and it's been highly engaging. I think finally, I should also congratulate Dr. Chandrika for coming up with such a wonderful program and getting the best of the faculty, because the success of the program depends upon its content and who gives the talks. So, and the amount of effort she's put in connecting to the faculty and making sure the program runs on time and things happen well, a huge amount of applause to her. And with this, I think it was a wonderful 3 days spent, and we thank all of you for your active participation, and hope that we can have similar kind of meetings in the future. Good night and have a wonderful weekend.
Thank you all. Goodbye.
Bye-bye.
Bye-bye. Nice weekend. See you. Ciao Narendra. Bye.
Bye-bye, sir.
Bye-bye. See you soon, hopefully, in person.
Yes.